Welcome, curious minds, to the deep dive. Today we're plunging into the core of one of the human body's most enigmatic and, frankly, unforgiving organs.
That's a good word for it.
Yeah, it's an organ tucked away so deeply in your abdomen that surgeons often approach it with extreme caution, describing it as the most unforgiving they encounter.
Uh-huh.
This vital gland has a profound dual nature, and when something goes wrong here, the impact on your health can be devastating.
It's true. This organ, despite its relatively small size, is a true master of both digestion and metabolic regulation. Its complexity means that pathology, whether it's, acute inflammation or maybe a subtle tumor, can present in incredibly vague yet ultimately life-threatening ways.
Yeah.
Understanding it demands the kind of meticulous insight that elite professionals in the medical field possess.
Exactly. So our mission for this deep dive is to go far beyond surface-level understanding. We're going to explore every single facet of this complex gland, from its intricate anatomy and vital functions to the challenging diseases that afflict it and the cutting-edge treatments aiming to restore health.
Right.
We want to give you a mastery-level understanding, drawing from a stack of highly authoritative sources, including pre-surgical texts. You'll get a comprehensive yet digestible journey into why this organ demands such respect and meticulous understanding, and why it holds so many surprising secrets.
And we aim to distill key takeaways from all our sources, ensuring you gain a balanced perspective and truly grasp the core concepts, not just a jumble of facts.
All right, let's unpack this. Our focus today is the pancreas, truly an unforgiving master of the abdomen. Let's start with its gross anatomy, getting a real map of where it sits and what makes it such a critical and often dangerous neighbor.
Indeed. The pancreas is notoriously described by surgeons as the most unforgiving organ. And that reputation is, it's well-earned. Its deep central position in the abdomen, lying obliquely from the C-loop of the duodenum up towards the splenic hilum, is key. It's surrounded by an incredible number of important structures and major blood vessels.
Right.
This means that even seemingly minor trauma can rupture pancreatic cells, leading to the uncontrolled release of highly potent digestive enzymes. This autodigestion can rapidly escalate into life-threatening pancreatitis, making surgical precision and anatomical knowledge just paramount in any abdominal procedure near it.
And it's not just its central location, right?
Yeah.
Its retroperitoneal reality plays a huge role in how disease manifests.
Absolutely. The fact that the pancreas is a retroperitoneal organ, meaning it lies behind the peritoneum, the membrane lining the abdominal cavity, explains why pathologies like pancreatic cancer often present with poorly localized, vague, or, ill-defined upper abdominal discomfort. It can be months before a cancer without bile duct obstruction is diagnosed because the pain is not easily pinpointed.
Right.
And when pancreatitis strikes, patients frequently describe the pain as penetrating through to the back, a direct consequence of its deep retroperitoneal position against the spine.
That makes sense.
This deep hidden nature is part of what makes it so unforgiving. Problems can brew unnoticed until they are quite advanced.
So, anatomically, how do surgeons typically divide this organ, and what are its dimensions?
Surgeons generally recognize 4 distinct regions: the head, neck, body, and tail. The adult pancreas typically weighs between 75 to 100 grams and measures about 15 to 20 centimeters long.
Okay.
The head is arguably the most crucial region from a surgical perspective. It's nestled within the C-loop of the duodenum and lies posterior to the transverse mesocolon.
Right.
Just behind the pancreatic head, you'll find major structures like the vena cava, the right renal artery, and both renal veins. It's a remarkably dense area for vital structures.
That's a busy neighborhood. What about the neck?
The neck of the pancreas is a critical landmark. It sits directly anterior to the portal vein, right where the superior mesenteric vein joins the splenic vein.
The confluence.
Exactly, the confluence. This forms the portal vein, which then continues towards the porta hepatis. The unstarted process, which is part of the head, wraps around the right side of the portal vein and extends posteriorly, ending near the space between the superior mesenteric vein and artery.
Okay.
It's also important to note that the neck of the pancreas is positioned anterior to the L1 and L2 vertebrae.
Oh, interesting.
Yeah, this makes it particularly vulnerable to blunt anteroposterior trauma, where force to the front of the abdomen can compress the pancreatic neck directly against the spine, potentially causing parenchymal and even ductal injury.
Ouch. And the body and tail.
The body and tail extend upwards and to the left, lying just anterior to the splenic artery and vein. The splenic vein actually runs in a groove along the back of the pancreas, receiving numerous fragile branches from the pancreatic parenchyma. These branches have to be carefully divided during certain surgical procedures, like spleen-sparing distal pancreatectomy.
Right.
The anterior surface of the body of the pancreas is covered by peritoneum, forming the floor of the lesser sac, which has significant implications.
Like with pseudocysts.
Exactly. Pancreatic pseudocysts, those fluid collections resulting from pancreatitis, commonly develop in this area. The posterior wall of the stomach can form the anterior wall of a pseudocyst, allowing for drainage directly into the stomach.
Makes sense.
Similarly, the base of the transverse mesocolon attaches to the inferior margin of the body and tail, often forming the inferior wall of pseudocysts, enabling surgical drainage through that route too.
Finally, a quick mention of the common bile ducts relationship.
Yes, the common bile duct runs in a deep groove on the posterior aspect of the pancreatic head, eventually passing through the pancreatic parenchyma to join the main pancreatic duct at the ampulla of Vater.
Okay.
This intimate relationship means that pathologies in the pancreatic head can easily compress or obstruct the bile duct, leading to jaundice.
Okay, now that we have a clear map of where the pancreas sits, let's unpack its internal plumbing system, the pancreatic ducts. This is where things get even more intricate, showing us why such a small organ can cause such big problems.
Indeed. To truly appreciate the variations in pancreatic duct anatomy, we need to briefly touch on its embryological origins. The pancreas actually forms from two distinct parts, a smaller ventral bud and a larger dorsal bud.
Two buds.
Two buds. The duct from the ventral bud becomes the duct of Wirsung, which connects directly to the common bile duct. The duct from the dorsal bud becomes the duct of Santorini and originally drains directly into the duodenum.
Okay.
As the gut rotates during development, the ventral anlage rotates to the right and fuses with the dorsal bud in most cases.
Right.
This fusion typically means that the majority of the pancreas drains through the larger duct of Wirsung, or the main pancreatic duct, into a common channel formed with the bile duct emptying at the major papilla.
So if they don't fuse, that's where we see the anomalies, right?
Exactly. The duct of Santorini from the dorsal anlage can persist as a lesser pancreatic duct, sometimes draining directly into the duodenum through a smaller, lesser papilla, located about 2 centimeters proximal to the major papilla.
Correct.
In about 30% of patients, this duct of Santorini ends blindly and doesn't empty into the duodenum at all.
That's quite a variation. What's the most common and clinically significant anatomical variant of the pancreatic ducts?
That would be pancreas divisum, a crucial anatomical variant occurring in about 10% of patients.
2%. Wow.
Yeah, it's quite common. In these individuals, the ducts of Wirsung and Santorini fail to fuse completely.
So they stay separate.
They stay separate. This means the majority of the pancreas, derived from the dorsal bud, drains through the smaller duct of Santorini and the lesser papilla. Only the inferior portion of the pancreatic head and the unsonidate process from the ventral anlage drain through the duct of Wirsung and the major papilla.
Why is that clinically significant?
Well, the significance lies in the fact that for a minority of these patients, the minor papilla can be inadequate to handle the flow of pancreatic juices from the bulk of the gland.
Like a bottleneck.
Exactly, a relative outflow obstruction. This can lead to recurrent episodes of acute pancreatitis and sometimes even chronic pancreatitis. It's a subtle anatomical difference that can have profound implications for a patient's health, making diagnosis challenging. While minor papillus sphincteroplasty, a surgical incision of the papilla, is sometimes employed to treat this, its long-term role remains debated.
It sounds like a plumbing bottleneck.
Yeah.
What about the main pancreatic duct itself?
The main pancreatic duct, or duct of Wirsung, is typically only 2 to 3 millimeters in diameter and runs centrally within the pancreas, usually a bit closer to the posterior surface.
Okay.
Interestingly, the pressure inside the pancreatic duct is about twice that in the common bile duct.
Really?
Well, this pressure differential is thought to be a protective mechanism, preventing the reflux of bile into the pancreatic duct, which could potentially activate pancreatic enzymes prematurely, leading to autodigestion.
Ah, preventing that self-destruction.
Precisely.
And it all eventually empties through the ampulla of Vater.
Yes. Both the main pancreatic duct and the common bile duct typically join at the ampulla of Vater, or the major papilla, located on the medial aspect of the second portion of the duodenum.
Right.
Surrounding this ampulla are muscle fibers that form the sphincter of Oddi, which precisely controls the flow of both pancreatic and biliary secretions into the duodenum.
Okay.
Its contraction and relaxation are under complex neural and hormonal regulation, ensuring digestive enzymes and bile are released only when needed.
So the internal plumbing is critical, but what about the lifeblood and communication lines that keep this organ functioning?
Yeah.
Let's talk about its vascular and lymphatic anatomy.
The pancreas boasts a remarkably rich blood supply, essential for its high metabolic activity. The body and tail, for instance, are primarily supplied by multiple branches of the splenic artery, which originates from the celiac trunk and runs along the posterior superior border of these pancreatic regions.
Okay.
The inferior pancreatic artery, usually arising from the superior mesenteric artery, also contributes, running parallel to the splenic artery along the inferior border of the body and tail. These vessels form intricate arcades, ensuring ample blood flow throughout the organ.
But there are some important variations that surgeons need to be incredibly aware of, right? Something that could turn a routine surgery into a crisis.
Absolutely. This is where anatomical variations can have truly unforgiving consequences. In a significant percentage of patients, about 15% to 20%, there's an anatomical variation known as the replaced right hepatic artery.
Replaced right hepatic artery. Okay.
Yeah. This is where the right hepatic artery, instead of arising from the common hepatic artery, originates from the superior mesenteric artery and then travels upwards, posterior to the head of the pancreas, towards the liver.
Behind the pancreas head.
Behind it.
Okay.
Preoperative identification of this variation is critically important, typically done via thin-cut multi-detector CT scans.
Right.
Missing it during surgery could lead to inadvertent injury, resulting in hepatic necrosis due to a compromised blood supply to the liver, a severe and avoidable complication.
Wow.
It underscored how every detail matters in pancreatic surgery.
That's a huge detail to miss. How about the venous drainage?
The venous drainage of the pancreas largely parallels its arterial supply. The splenic vein, for instance, runs along the back of the pancreas, collecting blood from the body and tail,
Okay.
while veins draining the pancreatic head and uncinate process typically enter along the right lateral and posterior sides of the portal vein.
Right.
A key surgical plane often can be developed between the neck of the pancreas and the portal and superior mesenteric veins, as there are usually no anterior venous tributaries, unless, of course, a tumor has invaded the vein.
And the lymphatic system, how does that connect to pancreatic disease, especially cancer?
The lymphatic drainage from the pancreas is remarkably diffuse and widespread. This extensive network of lymphatic vesseleth and nodes provides multiple routes for tumor cells to egress from the pancreas.
Mm-hmm.
This diffuse lymphatic drainage directly explains the high incidence of lymph node metastases and local recurrence commonly seen in pancreatic cancer patients, even after seemingly a complete resections.
Right, even if they think they got it all.
Exactly. Tumors located in the body and tail of the pancreas are particularly notorious for metastasizing to distant nodes, such as those in the transverse mesocolon and the mesentery of the proximal jejunum, often rendering them unresectable by the time of diagnosis. Understanding this network is vital for staging and treatment planning, but it's also a major reason why pancreatic cancer is so aggressive and difficult to cure.
The body is incredibly interconnected, and the pancreas is no exception. Its nervous system plays a huge role, especially when it comes to pain. Let's delve into the neuroanatomy.
The pancreas is richly innervated by both the sympathetic and parasympathetic nervous systems.
Okay.
Both systems supply the exocrine cells, which produce digestive enzymes, the endocrine cells in the islets that secrete hormones, and even the tiny blood vessels within the islets.
Right.
The parasympathetic system primarily stimulates both exocrine and endocrine secretion, essentially telling the pancreas to get to work. Conversely, the sympathetic system generally inhibits these secretions.
Are there other types of neurons involved?
Yes. The pancreas also contains neurons that secrete various amines and peptides, such as somatostatin, vasoactive intestinal peptide or VIP, calcitonin gene-related peptide, and galanin. While their precise roles in pancreatic physiology are still being fully elucidated, they do appear to influence both the digestive and hormonal functions of the gland.
What about the pain? The intense pain associated with pancreatic conditions is almost legendary. Why is it so severe?
That's due to the pancreas's rich supply of afferent sensory fibers. These are the nerve fibers that transmit signals from the organ back to the central nervous system.
Okay, the sensory input.
Exactly. In conditions like advanced pancreatic cancer or severe acute and chronic pancreatitis, these fibers are responsible for the excruciating and often debilitating pain patients experience.
Why?
These somatic fibers travel superiorly and converge at the celiac ganglia, a cluster of nerves located near the aorta in the upper abdomen.
Ah, the celiac plexus.
Precisely. This anatomical detail is clinically significant because interrupting the transmission of these pain signals at the celiac ganglia through a procedure called a celiac plexus block can provide significant pain relief for patients suffering from severe pancreatic pain. The fact that the pain pathways are so direct and concentrated is another reason the pancreas can be so unforgiving when diseased.
Beyond its structure and connections, the pancreas is a powerhouse of production. Let's delve into its dual physiological identity, covering both its exocrine and endocrine functions. This is where we truly see its mastery over digestion and metabolism.
The pancreas truly lives a dual life, and its mass distribution reflects this. About 85% of the pancreatic mass is dedicated to its exocrine function, meaning it produces and secretes digestive enzymes.
85%?
Yeah, the vast majority. Only about 2% of the gland is composed of endocrine tissue, which is responsible for hormone production. The remaining 10% is extracellular matrix, and 4% is blood vessels and ducts.
It's remarkable how these seemingly separate components work together.
It's an elegantly coordinated system. Despite their distinct functions, the exocrine and endocrine components aren't isolated. Their physical proximity, the presence of specific islet hormone receptors on the plasma membranes of pancreatic acinar cells, and the existence of an islet acinar portal blood system all facilitate a complex and elegant regulatory feedback system.
Interesting.
This coordination allows the pancreas to precisely regulate the type and rate of digestion and the subsequent processing and distribution of absorbed nutrients.
Let's first unwrap the digestive workhorse, the exocrine pancreas. How does it produce these powerful enzymes?
The exocrine pancreas is primarily made up of acinar cells, which are specialized to synthesize and secrete digestive enzymes.
Okay.
These enzymes are initially stored as inactive precursors called zymogen granules within the acinar cells. When stimulated, these zymogen granules are released into the lumen of the acinus. There, they combine with water and bicarbonate, which are secreted by specialized cells called centroacinar cells and ductal cells. This mixture, known as pancreatic juice, then travels through a complex network of ducts.
What are the key enzymes involved in digestion, and what do they do?
There are several crucial enzymes, each targeting specific macronutrients. First, there's amylase. It's unique because it's secreted in its active form.
Active right away.
Active right away. Amylase hydrolyzes starch and glycogen into simpler sugars like glucose, maltose, and dextrins, continuing the digestive process that begins in the mouth.
Okay.
Next, we have the proteins. These include endopeptidases like trypsinogen, chymotrypsinogen, and prolastase. Trypsinogen is activated by an enzyme called enterokinase, found in the duodenum to become active trypsin.
Trypsin is the key.
Trypsin is critical because it then activates chymotrypsinogen, pyrrolastase, and other enzymes like carboxypeptidase A and B and phospholipase. Trypsin, chymotrypsin, and elastase work by cleaving bonds between amino acids within a target peptide chain. Then there are the exopeptidases, primarily procarboxypeptidase A and B. Once activated by trypsin, they cleave amino acids specifically from the ends of peptide chains.
Okay, snipping off the ends.
Exactly. The resulting individual amino acids and small dipeptides are then actively transported into the intestinal epithelial cells for absorption.
So it's a cascade, with trypsin as the key activator. What are the implications if this activation goes wrong?
This is a critical point that directly ties into the pancreas's unforgiving nature. Trypsinogen is expressed in several isoforms, and a specific gene mutation, PRSS1, can lead to premature intrapancreatic activation of trypsinogen.
Inside the pancreas itself.
Inside the pancreas. This single gene mutation accounts for about 2/3 of cases of hereditary pancreatitis, where the pancreas essentially starts to digest itself from within.
Wow.
It highlights just how critical the precise, regulated activation of these enzymes is for pancreatic health. If this process goes awry, the consequences are severe autodigestion.
What about fat digestion?
For fats, we have pancreatic lipase, which hydrolyzes triglycerides into monoglycerides and fatty acids. It's also secreted in an active form.
Also active, okay.
Yeah. Collapase, also secreted by the pancreas, binds to lipase, which changes its molecular configuration and significantly increases its activity. Phospholipase A2 is secreted as a proenzyme and becomes activated by trypsin. It hydrolyzes phospholipids and, like all lipases, requires bile salts to function effectively.
Right, needs bile.
Needs bile. Finally, cholesterol esterase hydrolyzes neutral lipid substrates like cholesterol esters, fat-soluble vitamins, and triglycerides. Once hydrolyzed, these fats are packaged into micelles, which are then transported into the intestinal epithelial cells.
Okay.
From there, the fatty acids are reassembled and packaged into chylomicrons for transport through the lymphatic system into the bloodstream. It's a remarkably efficient and complex process to break down dietary fats.
You mentioned that centroacinar and ductal cells also secrete water and bicarbonate. What's the significance of that?
The water and bicarbonate secretion is crucial for neutralizing the acidic chyme that enters the duodenum from the stomach, creating an optimal pH environment for the pancreatic enzymes to function.
Right, neutralizing the acid.
Exactly. As the secretory rate of pancreatic juice increases, so does the concentration of bicarbonate, and inversely, the chloride secretion decreases. This reciprocal relationship helps maintain a consistent electrolyte balance.
And sometimes this process can go awry, leading to protein plugs.
Yes. When there's an increased protein content in pancreatic juice, often coupled with a decreased concentration of bicarbonate or trypsin inhibitors, a situation sometimes seen, for example, with chronic alcohol exposure, these proteins can precipitate. This leads to the formation of protein plugs, which can obstruct the pancreatic ducts and contribute to pancreatic injury and inflammation.
While the exocrine pancreas handles digestion, a tiny fraction of the gland has an equally monumental task, regulating our metabolism. Let's turn our attention to the endocrine pancreas and its hormonal regulators.
The endocrine pancreas is comprised of nearly 1 million tiny clusters of cells called the islets of Langerhans, which vary greatly in size and are distributed throughout the gland.
1 million islets.
Almost 1 million. The larger islets tend to be located closer to major arterioles, while smaller ones are embedded deeper within the pancreatic parenchyma. Each islet is a miniature endocrine factory containing typically 3,000 to 4,000 cells of 5 major types.
Okay.
Each specializing in secreting specific hormones that are crucial for glucose regulation.
Yeah, what are these 5 major cell types and their primary hormones?
The most abundant are the beta cells, making up about 70% of the islet mass, and they secrete insulin.
The famous one.
The famous one. Then there are alpha cells, comprising about 10%, which secrete glucagon. Delta cells make up about 5% and secrete somatostatin. The remaining cells include epsilon cells, which secrete ghrelin, and PP cells, which secrete pancreatic polypeptide, making up about 15% of the islet mass.
Insulin is perhaps the most well-known. Can you give us some historical context on its discovery?
The discovery of insulin in 1920 by Frederick Banting, an orthopedic surgeon, and Charles Best, a medical student, was a monumental achievement in medicine leading to a Nobel Prize.
Right.
They ingeniously induced diabetes in dogs by performing total pancreatectomy and then successfully treated them with crude pancreatic extracts. Their key insight was developing techniques to prevent the breakdown of insulin by the very potent proteolytic enzymes of the exocrine pancreas.
Protecting it from digestion.
Exactly.
How is insulin structured and synthesized?
Insulin is a 56 amino acid peptide synthesized as a precursor called proinsulin in the endoplasmic reticulum. Proinsulin is then transported to the Golgi complex, where it's packaged into granules and processed.
Okay.
During this processing, a connecting peptide, or C-peptide, is cleaved off, leaving the mature insulin molecule with its alpha and beta chains joined by disulfide bridges.
Right.
This C-peptide serves as an important clinical marker as it's secreted in equal amounts with insulin and can be measured to assess endogenous insulin production.
And how is it secreted and regulated?
Insulin secretion occurs in 2 phases. Following a glucose challenge, there's an initial rapid release of pre-stored insulin, known as the first phase, which lasts about 5 minutes.
Quick burst?
Quick burst. This is followed by a longer, sustained release, the second phase, which reflects the ongoing production of new insulin. Beta cell synthesis and secretion are tightly regulated by plasma glucose levels. Glucose is the primary stimulus.
Okay.
They're also influenced by neural signals like cholinergic fibers, which stimulate release, and by the paracrine influence of other islet cells within the pancreas.
Is there a difference in how the body responds to oral versus intravenous glucose?
Yes, this is quite fascinating. Oral glucose is a significantly more vigorous stimulus to insulin secretion compared to intravenous glucose.
Why is that?
This is because oral glucose not only enters the bloodstream, but also triggers the release of certain enteric hormones from the gut, known as incretins.
Incretins, okay.
These include gastric inhibitory peptide, or GIP, glucagon-like peptide 1, or GLP-1, and cholecystokinin, or CCK. These incretin hormones powerfully augment insulin secretion, leading to a more robust insulin response from the beta cells.
What else influences insulin release?
Beyond glucose and incretins, insulin secretion is influenced by plasma levels of certain amino acids, such as arginine, lysine, and leucine, and also by free fatty acids.
Okay.
Glucagon, GIP, GLP-1, and CCK all stimulate insulin release, while somatostatin, amylin, and pancreastatin inhibit it. Neuroregulation is also important. Cholinergic fibers and alpha-sympathetic fibers stimulate release, while beta-sympathetic fibers inhibit it.
What's insulin's main job? Its glucoregulatory function.
Insulin's primary glucoregulatory function is to lower plasma glucose levels. It achieves this by inhibiting endogenous glucose production, especially from the liver, and by facilitating glucose transport into cells throughout the body, particularly into muscle and adipocytes, where it can be used for energy or stored. Additionally, insulin inhibits glycogenolysis, which is the breakdown of stored glycogen into glucose, fatty acid breakdown, and ketone formation. Conversely, it stimulates protein synthesis and glucose uptake.
Given its vital role, does the pancreas have a lot of functional reserve when it comes to insulin production?
It does, surprisingly so. In a healthy pancreas, there's a considerable amount of functional reserve in insulin secretory capacity. In fact, roughly 80% of the pancreas can be surgically resected without the patient becoming overtly diabetic.
80%? That's amazing.
It is. However, and this is a crucial distinction, in patients whose pancreas is already diseased, such as those with chronic pancreatitis, even a smaller fraction of pancreatic resection can lead to pancreatogenic diabetes, also known as type 3C diabetes.
So the underlying health matters.
It matters hugely. This highlights the importance of the underlying health of the gland. It's not just about how much pancreas is left, but the quality of that remaining tissue.
And what about insulin receptors? How do they play into this?
Insulin receptors are dimeric tyrosine kinase containing transmembrane proteins found on virtually all cells in the body. Their regulation is key to how cells respond to insulin.
Okay.
In conditions of insulin deficiency, such as type 1 diabetes or pancreatogenic type 3C diabetes, there's often an upregulation or overexpression of insulin receptors.
The receptors.
More receptors. This results in an enhanced sensitivity to insulin in muscle and adipocytes, which paradoxically can increase the risk of insulin-induced hypoglycemia during treatment.
Oh, right.
In contrast, type 2 diabetes is typically associated with a downregulation of insulin receptors and a state of relative hyperinsulinemia, leading to insulin resistance where cells don't respond effectively to insulin. Some forms of diabetes, including pancreatogenic or type 3C diabetes, involve specific impairments of hepatic or peripheral insulin receptors.
So if insulin is the glucose-lowering hormone, what's glucagon's role?
Glucagon, secreted by the alpha cells, serves as insulin's crucial counterbalance. Its primary function is the exact opposite of insulin. It increases hepatic glycogenolysis, which is the breakdown of stored glycogen in the liver, and gluconeogenesis, the production of new glucose from non-carbohydrate sources, both of which raise blood glucose levels.
Raising blood sugar?
Raising blood sugar. The same neural impulses that regulate insulin also regulate glucagon, ensuring a finely tuned balance to maintain stable glucose levels.
Okay.
However, in pancreatogenic or type 3C diabetes, a significant clinical challenge arises. The glucagon responsiveness to a fall in blood glucose is often lost. Often lost. This severely impairs the body's natural defense against hypoglycemia, significantly increasing the risk of dangerously low blood sugar. This is a key reason why managing type 3C diabetes is so complex and can be so brittle, as we'll discuss later.
And somatostatin, what does that do?
Somatostatin, secreted by the delta cells, is often referred to as the universal inhibitor due to its widespread inhibitory effects.
Universal inhibitor, okay.
Yeah. While originally isolated from the hypothalamus, it's found throughout the body, including the pancreas and gut. It inhibits the secretion and action of virtually all pancreatic and gut peptides, including insulin and glucagon.
Wow.
It also influences cell growth, neurotransmission, gastrointestinal and biliary motility, intestinal absorption, and vascular tone. Its release is stimulated by intraluminal fat and acid during a meal, but notably inhibited by acetylcholine from cholinergic neurons.
How about pancreatic polypeptide, or BP?
Pancreatic polypeptide, a 36 amino acid peptide, was discovered by Kimmel in 1968 during insulin purification. Its release is potently stimulated by dietary protein and fat, with glucose having a weaker effect.
Okay.
Hypoglycemia, regardless of its cause, strongly stimulates PP secretion via cholinergic input. Vagal stimulation is its most important regulator. A vagotomy, for instance, eliminates the post-meal rise in PP, which can even be used as a test for the completeness of a surgical vagotomy. While PP inhibits choleresis, gallbladder contraction, and exocrine secretion, its most important role is in glucose regulation, specifically through its influence on hepatic insulin receptor gene expression.
Hepatic insulin receptor.
Exactly. A deficiency in PP secretion, which can occur after proximal pancreatectomy in severe chronic pancreatitis or with cystic fibrosis, is linked to diminished hepatic insulin sensitivity. What's remarkable is that this effect can actually be reversed by PP administration,
Really?
highlighting its potential as a therapeutic target and hinting at the intricate balance the pancreas maintains.
You also mentioned ghrelin. That's usually known as the hunger hormone. Does it have a role in the pancreas too?
Yes, ghrelin, secreted by the epsilon cells within the islets and also in large amounts by the gastric fundus, is indeed known for stimulating growth hormone secretion and for its role in regulating appetite.
Right.
But within the islet, it plays a modulating role. Ghrelin has been shown to block insulin's effects on the liver and to inhibit the beta cell response to incretin hormones and glucose. So ghrelin secretion from within the islet can significantly modulate the responses of other islet cells to nutrient and hormonal stimuli, adding another layer to the pancreas's complex regulation.
It's a lot of specialized cells and hormones. Does their distribution within the pancreas matter clinically?
It absolutely does. While beta and delta cells are generally evenly distributed throughout the pancreas, there's a distinct diversity depending on the region.
Okay.
Islets in the head and unselenic process, which originate from the ventral anlage embryologically, have a higher percentage of PP cells and fewer alpha cells.
More PP cells in the head.
Right. Conversely, islets in the body and tail, derived from the dorsal anlage, contain the majority of alpha cells and fewer PP cells.
Mostly alpha cells in the tail.
Exactly. This distribution has significant clinical relevance. For example, a pancreaticoduodenectomy, commonly known as a Whipple procedure, removes about 95% of the PP cells in the pancreas.
Wow, almost all of them.
Which may partially explain the higher incidence of glucose intolerance after this procedure compared to a distal pancreatectomy, even if a similar amount of tissue is resected.
Right.
Similarly, chronic pancreatitis, which often disproportionately affects the pancreatic head, is associated with PP deficiency and pancreatogenic diabetes. And the relative preponderance of alpha cells in the body and tail explains why leukogonomas, a type of tumor, are typically found in those regions.
The pancreas is incredibly complex in its normal state, but it becomes a battleground when inflammation sets in, particularly in conditions like acute pancreatitis. Let's shift our focus to the fire within.
Acute pancreatitis is indeed an inflammatory disorder of the pancreas, characterized by edema and, in severe cases, necrosis. It's a common and challenging disease, ranging from a mild, self-limiting inflammation to a severe and critical condition marked by infected pancreatic necrosis, multiple organ failure, and a high mortality. While the traditional view suggested complete resolution, necrotizing pancreatitis can leave significant scarring, strictures, and persistent impairment of both exocrine and endocrine pancreatic function.
So the damage can last.
The initial fire may quell, but its damage can linger, a testament to the organ's unforgiving nature.
What's the scale of this problem?
Acute pancreatitis is actually the most common inpatient principal gastrointestinal diagnosis in the United States, with over 274,000 admissions in a recent year.
That's huge.
It is. The incidence has been increasing, and it's associated with the highest aggregate inpatient costs among GI diagnoses, totaling billions annually. It ranks as a significant cause of both overall and gastrointestinal-related deaths in the U.S.
Wow.
Incidence varies globally, and there's also ethnic variation. Notably, smoking has been identified as an independent risk factor.
What sparks this internal fire? The causes are varied, but some are far more common than others. Let's discuss the etiology of acute pancreatitis.
The onset of acute pancreatitis can be triggered by many factors, though the precise mechanism is often not fully understood. However, the most common culprits, accounting for up to 80% of cases, are gallstones and alcohol.
Gallstones and alcohol, the big two.
The big two. It's important to have a systematic approach to identifying all potential causes, as some cases are labeled idiopathic when no obvious cause is found. The median age of presentation can vary with the etiology. Alcohol and drug-induced pancreatitis often appear in younger adults, while gallstone or trauma-induced cases tend to occur in older individuals.
How do gallstones cause an attack?
The evidence linking gallstones to acute pancreatitis is compelling. We often see transient derangement of liver function tests, and strikingly, small gallstones are retrieved from the feces in a high percentage of patients shortly after an attack.
Okay.
The most favored idea is that the gallstone transiently obstructs the pancreatic duct, leading to ductal hypertension.
Back pressure.
Back pressure. This might then cause minor ductal disruption, allowing pancreatic juice to extravasate into the less alkaline pancreatic interstitium, prematurely activating enzymes and initiating inflammation.
Right.
It's also worth noting that many cases previously labeled idiopathic acute pancreatitis are now found to be due to occult microlithiasis microscopic gallstones detectable via bile microscopy.
Tiny stones causing big problems.
Precisely.
And alcohol, which is also a huge factor. How does it damage the pancreas?
Alcohol ingestion is strongly associated with acute pancreatitis, and sustained heavy consumption is a major driver of recurrent attacks and eventually chronic pancreatitis in susceptible individuals.
Right.
The quantity consumed and the drinking pattern are more important than the type of alcohol. Ethanol causes damage through multiple mechanisms. In acinar cells, its metabolism produces changes that predispose the cells to autodigestive injury and cell death. Ethanol also activates pancreatic stellate cells, transforming them into myofibroblast-like cells that produce pro-inflammatory mediators. This initial secretory burst, combined with potential ethanol-induced spasm of the sphincter of Oddi, is thought to incite acute pancreatitis.
Okay.
Furthermore, ethanol increases ductal permeability, allowing prematurely activated enzymes to leak and cause damage to pancreatic parenchyma.
So it makes the ducts leaky.
Leaky ducts. In a vicious cycle, it also increases the protein content of pancreatic juice while decreasing bicarbonate levels and trypsin inhibitor concentration, which can lead to the formation of protein plugs, contributing to duct obstruction, especially in chronic pancreatitis.
Are there other notable causes besides these two major ones?
Yes. Iatrogenic causes, particularly procedures like endoscopic retrograde telangioppancreatography or ERCP, are known triggers.
Right, ERCP induced.
Yeah, exactly. Hereditary pancreatitis, often linked to gene mutations that lead to premature activation of trypsinogen to trypsin, directly promotes acute pancreatitis. Mutations in SPNK1, a trypsin inhibitor protein, also play a role by compromising the body's natural defense against trypsin.
Okay.
Pancreatic or periampullary tumors should also be considered, especially in patients over 50 years old with idiopathic acute pancreatitis, as an acute episode can be their first clinical indicator. Cross-sectional imaging after resolution of inflammation is essential in these cases.
Good point.
Lastly, hyperlipidemia, especially certain types, can trigger pancreatitis. High triglyceride levels are thought to liberate toxic fatty acids into the pancreatic microcirculation, causing localized ischemia and damage.
Understanding the triggers is one thing, but the real mystery lies in how these triggers unleash such devastating self-destruction within the pancreas. Let's delve into the pathophysiology, the autodigestive cascade.
The core concept of acute pancreatitis, first proposed in 1896, is autodigestion, the premature intrapancreatic activation of the organ's own digestive enzymes.
Self-digestion.
Self-digestion. This concept has been consistently demonstrated in animal models and is considered the key precipitating event. The central role of trypsin activation is particularly well supported. Studies show that mice lacking a specific trypsinogen isoform exhibit less pancreatic injury during acute pancreatitis.
Right.
And direct expression of active trypsin causes pancreatitis in mice. Hereditary pancreatitis, as we discussed, is directly linked to mutations that lead to elevated intracellular trypsin activation.
So the body's own protective mechanisms against autodigestion are overwhelmed.
Precisely. Under normal physiological conditions, the pancreas has multiple protective mechanisms. Enzymes are synthesized as inactive precursors, their production and activation sites are kept separate, and specific trypsin inhibitors are present within the gland.
Okay.
Acute pancreatitis occurs when these sophisticated protective measures are overwhelmed by erroneously activated enzymes, leading to injury.
What happens at the cellular level inside the acinar cells?
At the intraacinar level, several critical events occur. First, there's an inhibition of acinar cell secretion, meaning the enzymes aren't properly released into the ducts.
It gets stuck inside.
Simultaneously, the zymogen granules containing the inactive enzymes abnormally colocalize with lysosomal enzymes, particularly cathepsin B, within cytoplasmic vacuoles.
Uh-oh.
Uh-oh is right. Cathepsin B then prematurely activates trypsinogen into active trypsin within these vacuoles. A sustained increase in cytosolic calcium is critical for this colocalization to occur.
Calcium is key.
Calcium is key. Once trypsin is activated, it permeabilizes these colocalization vacuoles, releasing cathepsin B and other contents into the cytosol. Once in the cytosol, cathepsin B initiates apoptotic cell death
Programmed cell death.
by permeabilizing mitochondrial membranes, which leads to the release of cytochrome C and triggers the apoptotic cascade, causing the acinar cells to die. This is the very beginning of the self-digestion, a truly terrifying internal event.
And what happens beyond the individual acinar cells within the pancreas itself?
Once acinar cell injury initiates the process, a series of intrapancreatic events determine the severity of the pancreatitis. Activated neutrophils are drawn to the pancreas, where they release superoxide and proteolytic enzymes, causing further pancreatic injury.
More damage.
More damage. Concurrently, macrophages release powerful cytokines, including tumor necrosis factor alpha, TNFS, and various interleukins, IL-1, IL-2, IL-6, and IL-8, which mediate both local and systemic inflammation.
Right, the inflammatory response.
Exactly. These inflammatory mediators significantly increase pancreatic vascular permeability, leading to fluid collection in and around the pancreas, hemorrhage, edema, and the formation of microthrombi. In more severe cases, the failure of the pancreatic microcirculation results in profound pancreatic hypoperfusion and subsequent necrosis. Based on the presence or absence of necrosis, acute pancreatitis is morphologically classified as either interstitial edematous pancreatitis, where there's inflammation but no recognizable necrosis, or necrotizing pancreatitis, characterized by pancreatic hypoperfusion on contrast-enhanced CT.
This sounds like it quickly spirals out of control, affecting the entire body.
It does. The systemic events are a critical aspect of acute pancreatitis pathophysiology. A key mechanism linking the pancreatic events to widespread systemic inflammation and multi-organ failure is the NF-dependent inflammatory pathway.
NF-kappa B.
NF-kappa B. This pathway is activated by the sustained increase in cytosolic calcium that we discussed earlier, and once activated, NFI regulates the synthesis of numerous cytokines and chemokines.
Okay.
These, in turn, recruit various inflammatory cells that then magnify and propagate systemic inflammation throughout the body. Organ failure can develop at any stage of acute pancreatitis. It might occur early due to an overwhelming pro-inflammatory response, or later secondary to the development of infected local complications.
Right.
A particularly dangerous late complication is infected pancreatic necrosis, which typically peaks around 3 to 4 weeks after onset and is often associated with a severe systemic inflammatory response syndrome, SRRS, and multi-organ dysfunction syndrome or failure, MODSF.
This complex internal chaos demands a coordinated response. How do we diagnose acute pancreatitis and, more importantly, predict and manage its severity?
The management of acute pancreatitis requires a truly multidisciplinary approach with carefully coordinated care. The essential requirements are accurate diagnosis, appropriate triage, high-quality supportive care, and diligent monitoring for and treatment of complications.
What are the primary diagnostic criteria?
The diagnosis of acute pancreatitis relies on 2 out of 3 criteria. First, the patient must present with abdominal pain consistent with acute pancreatitis, typically an acute onset of severe, constant epigastric pain that often radiates through to the mid-back.
Okay, the classic pain.
Classic pain. Second, there must be a significant elevation of serum amylase or lipase levels, specifically more than 3 times the upper limit of normal.
3 times normal.
3 times normal. Using the pancreatic isoenzyme of amylase, or preferably lipase, is important due to other potential causes of hyperamylasemia. Imaging, usually by contrast-enhanced CT scanning, is only required if these initial diagnostic criteria are not met or if local complications are suspected.
You mentioned nuances with amylase levels. What should clinicians be aware of?
While serum amylase typically increases almost immediately and peaks within hours, remaining elevated for 3 to 5 days, it's crucial to understand that there is no correlation between the extent of amylase elevation and the severity of pancreatitis.
None at all.
None. In fact, milder forms can sometimes have higher levels. Hyperamylasemia can also be caused by other conditions like small bowel obstruction. Conversely, patients with acute pancreatitis can have normal serum amylase levels.
Right.
This might happen in hyperlipidemia due to assay interference or in very severe necrosis where the pancreas is so damaged it can't release large amounts of enzymes. For these reasons, measuring urinary amylase can be more sensitive as its levels often remain elevated for days after serum levels normalize.
Beyond lab tests, what physical signs might we see?
Clinical signs include significant abdominal tenderness, often with signs of peritonitis, particularly in the upper abdomen. Rarely, severe cases involving bleeding can manifest as Cullen's sign, a bruise-like discoloration around the umbilicus, or gray Turner's sign, which is bruising in the flanks.
Those rare bruising signs.
Exactly. Another rare sign is tetany, resulting from hypocalcemia. Patients often exhibit hemoconcentration due to fluid loss, with elevated blood urea nitrogen and creatinine levels, hyperglycemia, and hypoalbuminemia.
How do we predict the future severity and outcome, not just classify the present state?
Predicting severity is about assessing future risk. While various scoring systems like Ranson's criteria or the SOFA score are used, it's important to recognize their limitations. These systems typically have an accuracy of around 70%, meaning they can misclassify severity in a significant percentage of cases.
Only 70%.
Roughly. They should augment clinical judgment, not replace it. Key clues for clinicians over the first 2 to 3 days include a persistently elevated blood urea nitrogen or creatinine, or persistent systemic inflammatory response syndrome, SIRS, even after aggressive fluid resuscitation. These patients are at a higher risk of developing severe acute pancreatitis.
And how do we classify the present severity?
Classification or staging has evolved beyond a simple binary of mild or severe. Modern systems are graded based on the presence and nature of local complications, whether they're absent, sterile, or infected, and systemic complications absent, transient organ failure, or persistent organ failure.
Okay.
Two widely accepted systems are the revised Atlanta criteria, which categorize severity into mild, moderately severe, and severe, and the determinants-based classification, which uses 4 categories: mild, moderate, severe, and critical. Both have been independently validated and are broadly equivalent.
Once diagnosed, what's the immediate management?
Initial management, especially in the first 48 hours, is crucial. Aggressive fluid resuscitation is paramount to restore and maintain circulating blood volume.
Fluids.
Pretty much. However, surprisingly, the evidence base for fluid therapy is somewhat scant, with most recommendations based on expert opinion.
Really?
Yeah. While vigorous fluid therapy is often advocated, the best approach is probably to resuscitate with a balanced crystalloid, aiming to restore normal blood volume, blood pressure, and urine output. Lactated Ringer solution has shown superiority over normal saline in one study for reducing the systemic inflammatory response.
LR is better.
Seems to be. However, caution must be exercised in patients with cardiac or renal disease and in the elderly due to the risks of over-resuscitation. Pain management is also crucial and begins immediately.
What about nutritional support? Is it still rest the pancreas?
Absolutely not. The paradigm for nutritional support has shifted dramatically. It is no longer acceptable to rest the pancreas.
Big change.
Big change. Early enteral nutrition, initiated within 72 hours of admission, is now the mainstay of nutritional support. Enteral nutrition is less expensive, carries fewer risks, and is more effective than parenteral nutrition, which should only be used if enteral requirements cannot be met.
Okay.
For predicted mild acute pancreatitis, patients are encouraged to resume oral intake as desired once abdominal pain resolves, rather than waiting for normalization of enzyme levels.
And when do we use imaging like CT or MRI?
While CT scans might be used to confirm the diagnosis in unclear cases, they are not used to predict the severity of acute pancreatitis.
Not for severity.
Not for severity. Yeah. The primary purpose of cross-sectional imaging, like CT or MRI, is for the diagnosis of local complications, particularly to assess the development and extent of pancreatic necrosis and fluid collections. CT is also invaluable for guiding the insertion of percutaneous drains, which are playing an increasing role in managing local complications. MRI is superior to CT for detecting any solid content within these collections, which is crucial for distinguishing simple fluid from necrotic debris. If a bleed is suspected, an arterial phase CT scan, or CTA, is used to detect pseudoaneurysms or active bleeding.
What about therapeutic ERCP? Does everyone with gallstone pancreatitis get one?
Not everyone. Randomized trials show that early ERCP, performed within 24 to 48 hours, reduces complications, though not mortality, in patients with predicted severe gallstone-associated acute pancreatitis.
Only severe cases, then?
Primarily predicted severe cases. The benefits, such as treating cholangitis or releasing an impacted stone, must be weighed against risks like exacerbating pancreatitis. More recent evidence suggests that early ERCP offers no additional benefit without concomitant cholangitis, as the offending common duct stone often passes spontaneously. An MRCP can be used to detect a common duct stone as a prerequisite before attempting an ERCP in such cases.
And antibiotics. Prophylactic use has been controversial.
Yes, the use of broad-spectrum antibiotics for established infection in acute pancreatitis is standard practice. However, prophylactic antibiotics aiming to prevent infection have been a considerable controversy.
Right.
The current consensus, based on recent well-designed studies, does not support the use of prophylactic antibiotics to reduce infectious complications. Overuse of antibiotics is linked to a rise in fungal infections and resistant organisms, so they're reserved for confirmed infections.
How are local complications managed?
Vigilance and timely, accurate diagnosis of local complications are key, but the decision on when and how to intervene is often difficult. It's based primarily on the patient's clinical status and trajectory, not just imaging findings.
Clinical status first.
Right. There is a notable trend towards delaying interventions, often until 3 to 4 weeks after symptom onset, to allow for demarcation of the lesion, which reduces the risks of bleeding, disseminated infection, and collateral damage.
Wait for it to wall off.
Pretty much. Percutaneous catheter drainage is an important emerging approach for suspected infected collections. It can often stabilize the patient, buying time and allowing the lesion to wall off, and in some patients, it might be the only intervention required.
Okay.
Minimally invasive options are preferred, with open surgery reserved for those who fail a step-up approach, starting with percutaneous drainage and then potentially endoscopic or videoscope-assisted debridement. Endoscopic transgastric drainage is generally favored when feasible.
What about pseudocysts, a common complication?
Acute non-infected pseudocysts are often managed conservatively, as about half resolve spontaneously. Intervention is typically reserved for persistent symptoms like pain or inability to eat, or if infection occurs.
Okay.
Critically, percutaneous drainage should be avoided if the pseudocyst communicates with the main pancreatic duct due to the high risk of external pancreatic fistula.
Right. Don't want a fistula.
Definitely not. Instead, EUS-guided internal drainage into the stomach or duodenum or transpapillary stenting are preferred approaches. Sometimes complications from endoscopic drainage can necessitate surgical intervention.
And managing organ failure, which can be the most serious outcome.
Early identification of organ dysfunction and failure is paramount, as it's a key determinant of severity and outcome. Patients should be promptly transferred to an intensive care unit for specialized support and monitoring, often guided by scoring systems like the SOFA score.
ICU care.
ICU care. The responsiveness of organ failure to resuscitation within the first 48 hours is a crucial prognostic indicator. Those whose organ failure is transient tend to have a better outlook. Organ failure developing later in the disease course is usually secondary to an infected local complication, and its management is then tied to treating that infection.
To prevent recurrent attacks of gallstone pancreatitis, what's done?
Cholecystectomy, the surgical removal of the gallbladder, is essential to prevent recurrent gallstone-associated pancreatitis.
Gotta get the gallbladder out.
Absolutely. The question is timing. An index cholecystectomy, performed during the same hospital admission, is generally considered safe and is often done laparoscopically.
Okay.
However, it may not be suitable for all patients, particularly those with significant local pancreatic complications. In such cases, an interval cholecystectomy is performed later, after the inflammatory process has resolved.
Right.
If surgery is required for local complications, the cholecystectomy is often performed at the same time.
Finally, a surprising long-term consequence: diabetes.
Recent evidence indicates that both prediabetes and frank diabetes are remarkably common after acute pancreatitis, affecting nearly 40% of patients post-discharge.
40%, that's high.
It's very high. The prevalence of newly diagnosed diabetes is significantly higher compared to the general population. The risk of diabetes at least doubles after 5 years post-pancreatitis.
Wow.
Interestingly, the initial severity of the acute pancreatitis itself appears to have minimal effect on the long-term risk of developing diabetes.
Really? Severity doesn't matter for that.
It seems not for the long-term diabetes risk. The implication here is significant. Patients recovering from an acute pancreatitis attack require diligent follow-up and screening for glucose intolerance to catch this potential long-term complication early. It's a hidden consequence of the initial fire.
If acute pancreatitis is a sudden raging fire, chronic pancreatitis is a slow, smoldering burn causing progressive damage and posing unique challenges. Let's explore this incurable condition.
Chronic pancreatitis is a multifactorial, incurable, inflammatory condition of the pancreas, highly variable in its presentation and exceptionally challenging to treat successfully. Autopsy studies even show evidence of chronic inflammation like fibrosis, ductectasia, and acinar atrophy in some of the general population, though these changes can also be present in asymptomatic elderly individuals. Population studies suggest a prevalence ranging from 5 to 40 persons per 100,000, with notable geographical variations likely influenced by diagnostic criteria, regional nutrition, alcohol consumption, and access to medical care. The overall incidence of chronic pancreatitis has been progressively rising over the past 5 decades, making it a growing public health concern.
Like acute pancreatitis, understanding the why behind chronic pancreatitis is crucial, and it's a more complex whip of causes. Let's talk about its etiology.
Indeed, the causes are more diverse than acute pancreatitis. Genetic mutations play a significant role. Familial patterns of chronic, non-alcoholic pancreatitis have been described worldwide.
Hereditary forms.
Hereditary forms. These are autosomal dominant, often lead to calcific pancreatitis, and typically present in childhood or adolescence with abdominal pain. Progressive pancreatic dysfunction is common, and there's a significantly increased risk of pancreatic carcinoma, reaching up to 40% prevalence in some series, although cancer typically manifests after age 50.
What specific genetic mutations are involved?
A key mutation is on the categorising trypsinogen gene, PRSS1, specifically mutations like R122H and N29I. These are gain-of-function mutations.
Gain-of-function.
Yeah, meaning they lead to excess production of trypsinogen and critically persistent and uncontrolled proteolytic activity and autodestruction within the pancreas.
Right, back to that premature activation.
Exactly. These two PRSS1 mutations account for about 2/3 of hereditary pancreatitis cases. A gain-of-function mutation in the anionic trypsinogen gene, PRSS2, has also been found. Another important gene is SPNK1, which encodes an inflammation-induced trypsin inhibitor.
SPNK1, the inhibitor.
Right. Loss-of-function mutations in SPNK1 are associated with familial, idiopathic, and tropical forms of chronic pancreatitis. These mutations are surprisingly common in the general population and act as disease modifiers, weakening the pancreas's natural protective mechanisms against autodigestion.
And cystic fibrosis, usually thought of as a lung disease, connect to pancreatic issues, correct?
Yeah, that's right. Cystic fibrosis, caused by mutations in the CFTR gene, significantly impacts the pancreas. The CFTR protein is present in pancreatic duct cells and regulates chloride and bicarbonate secretion into pancreatic juice.
Okay.
While the classic pulmonary disease is often linked to a specific mutation, other CFTR mutations, even without severe pulmonary symptoms, are strongly associated with chronic idiopathic pancreatitis, autoimmune pancreatitis, and pancreas divisum.
Wow.
This means a CFTR mutation can predispose individuals to pancreatic disease even if they don't have the full-blown cystic fibrosis syndrome.
That's quite a surprising connection for many. Earlier, you mentioned a landmark study linking a specific gene to alcoholic chronic pancreatitis in men. What's the story there?
This was a groundbreaking discovery by Whitcomb and colleagues in 2012. They found a common DNA variant on the X chromosome, specifically involving the CLDN2 gene.
CLDN2 on the X chromosome.
Exactly. Found in nearly 50% of men diagnosed with alcoholic pancreatitis, compared to only 26% of men without pancreatitis. The CLDN2 gene encodes a tight junction protein normally found in ductal cells, but in chronic pancreatitis, this protein is abnormally expressed in acinar cells, which may alter enzyme release dynamics.
Okay.
The crucial point is that this CLDN2 variant doesn't cause pancreatitis directly. Instead, if pancreatitis occurs for any reason in a person with this variant, they are significantly more likely to develop the chronic form.
Increases susceptibility.
Increases susceptibility, and this risk is even further increased with alcohol consumption. This finding also helps explain why alcoholic chronic pancreatitis is so much more prevalent in men. Men only have one X chromosome, so if they inherit a CLDN2 mutation, they have no protection from a second normal X chromosome, unlike most women who would have two X chromosomes.
Fascinating.
It demonstrates a clear genetic susceptibility to a disease long thought to be purely environmental, adding another layer to the pancreas's unpredictable nature.
That's a huge shift in understanding. Now, back to alcohol itself. Beyond acute episodes, how does it lead to chronic pancreatitis?
While a link between alcohol and pancreatic disease has been observed for centuries, confirming a causal relationship for chronic pancreatitis has been complex. There is a clear linear relationship between alcohol exposure and the development of chronic pancreatitis.
A dose response.
A dose response. What's surprising is that there appears to be no threshold level of alcohol consumption below which there's absolutely no risk, perhaps due to the CLDN2 gene variant we just discussed.
That
While the risk is highest in heavy drinkers, only a small percentage of heavy abusers actually develop chronic pancreatitis, suggesting other contributing factors. Typically, the disease manifests after 16 to 20 years of heavy consumption. Patients often have recurrent episodes of acute pancreatitis for 4 to 5 years before chronic symptoms appear.
So it's not just a single exposure, but repeated injury.
Exactly. The widely accepted pathophysiological sequence for chronic pancreatitis involves multiple episodes of pancreatic injury or a prolonged course of damage that ultimately leads to chronic disease.
Yeah.
Alcohol metabolites like acetaldehyde combined with oxidant injury cause localized parenchymal damage. This repeated or severe toxin-induced injury activates a cascade of cytokines, which in turn induce pancreatic stellate cells, PSCs, to produce collagen, leading to the characteristic fibrosis of chronic pancreatitis.
The stellate cells make the scar tissue.
They do. This is part of the sentinel acute pancreatitis event, or SAPE hypothesis, where a critical episode of acute pancreatitis activates PSCs, leading to fibrosis.
And alcohol changes the pancreatic secretions, making it more prone to issues.
Yes, chronic alcohol exposure leads to a pancreatic juice that is high in protein, low in bicarbonate, and low in volume.
Thick and sluggish.
Kind of. This altered composition promotes the precipitation of proteins in the small ducts in early chronic pancreatitis. Calcium can then complex with these protein plugs, forming stones in the small ductules and eventually the main ductal system. This not only causes ductal cell injury, but also obstructs the secretory system, further promoting inflammation and damage.
Does smoking play a role here too?
Smoking is strongly associated with chronic pancreatitis and has been shown to accelerate the development of alcoholic pancreatitis. Beyond that, it significantly increases the risk of pancreatic cancer in patients with chronic pancreatitis, even lowering the age of cancer onset by about 20 years in hereditary pancreatitis.
Wow, 20 years earlier.
Yeah, so smoking appears to be an independent risk factor for the late complications of alcoholic pancreatitis and certainly a cofactor for fibrosis development.
Are there other metabolic causes of chronic pancreatitis?
Yes. Hyperparathyroidism, which causes chronic hypercalcemia, is a known stimulant for pancreatic hypersecretion and pancreatic calcium secretion. This contributes to calculus formation and obstructive pancreatopathy, leading to chronic calcific pancreatitis. Correcting the hyperparathyroidism is the primary treatment.
Okay.
Hyperlipidemia, specifically certain types, can also predispose women to chronic pancreatitis, especially if fasting triglyceride levels are elevated. It's thought to involve repeated subclinical episodes of acute inflammation.
Beyond causes, how is chronic pancreatitis generally classified by type?
Chronic pancreatitis is broadly classified into several types. The largest subgroup is chronic calcific lithogenic pancreatitis, which includes most etiologies and is characterized by stone formation and parenchymal calcification.
Calcific type.
Right. While many have a history of alcohol abuse, calcification alone doesn't confirm alcohol as the cause. It's also prominent in hereditary and tropical pancreatitis.
What about obstructive forms?
Chronic obstructive pancreatitis refers to inflammatory changes caused by compression or occlusion of the proximal ductal system by tumors, trauma, or anatomical variations like pancreas divisum.
Right, something blocking the duct.
Exactly. This leads to diffuse fibrosis and dilated ducts. The good news here is that both functional and structural abnormalities may improve if the obstructive process is relieved.
It's interesting how pancreas divisum resurfaces here as a cause of chronic obstructive pancreatitis. Can you elaborate on its role?
Pancreas divisum, the most common congenital pancreatic anomaly, is indeed a special case. It's thought to predispose individuals to recurrent acute and chronic pancreatitis due to a functional obstruction of the diminutive duct of Santorini.
The smaller duct.
The smaller duct, which drains the majority of the pancreas but fails to adequately communicate with Wirsung's duct. While the classic obstructive picture with a dilated dorsal duct is actually unusual in pancreas divisum, leading to skepticism about its direct role without other factors, endoscopic stenting through the lesser papilla can provide temporary symptomatic relief. This response can even help select patients who might benefit from a more permanent intervention. Furthermore, recent studies suggest that the presence of pancreas divisum, especially when combined with CFTR gene mutations, significantly increases the risk for chronic pancreatitis.
What about chronic inflammatory types?
Chronic inflammatory pancreatitis is characterized by diffuse fibrosis, loss of acinar cells, and a predominant infiltration of mononuclear cells throughout the gland. A significant variant here is autoimmune pancreatitis, AIP.
AIP.
AIP. This is a non-obstructive, diffusely infiltrative disease linked to autoantibodies and other autoimmune conditions. AIP can present as type 1, which involves systemic or multi-organ dysfunction, or type 2, which is restricted to the pancreas.
Okay.
It frequently causes compressive stenosis of the intrapancreatic portion of the common bile duct, leading to obstructive jaundice. Diagnosis is often supported by elevated serum IgG4 levels, and steroid therapy is remarkably effective.
Steroids work well.
Remarkably well, often normalizing pancreatic function. It's crucial to differentiate AIP from a lymphoma or carcinoma, and pancreatic biopsy helps confirm the diagnosis.
And tropical pancreatitis.
Tropical nutritional pancreatitis is highly prevalent in tropical regions. It typically presents in adolescents and young adults with abdominal pain, followed by a brittle form of pancreatogenic diabetes. Patients often develop large parenchymal and intraductal calcifications or stones.
Large stones.
Very large stones. It's associated with malnutrition and possibly toxic foodstuffs. Clinically, it resembles hereditary pancreatitis, and SBANK1 and CFTR mutations have been documented in these patients. Given global migration, awareness of this severe form of chronic pancreatitis is increasingly important for clinicians worldwide.
Is there such a thing as asymptomatic pancreatic fibrosis?
Yes, asymptomatic pancreatic fibrosis is observed in some elderly patients, tropical populations, and asymptomatic alcohol users. This involves diffuse perilobar fibrosis and acinar cell loss, but notably, there's no main ductular component.
Different pattern.
Different pattern. The presence of fibrosis and decreased exocrine function in patients with long-standing diabetes also raises questions about whether diabetes itself can cause chronic pancreatitis, though recent histopathologic studies indicate distinct morphological differences from typical chronic pancreatitis. It remains unknown if this form of chronic inflammation is a precursor or contributor to the increased risk of pancreatic cancer in patients with long-standing diabetes.
And finally, when no clear cause is found.
That's termed idiopathic pancreatitis. This group historically included young adults without a family history who might have spontaneous gene mutations, as well as older patients with no obvious cause for recurrent or chronic pancreatitis. However, with improved methods for detecting biliary calculi, many elderly idiopathic cases are now attributed to biliary tract disease. Variable SBANK1 and CFTR mutations have also been described in this group.
Regardless of the cause, chronic pancreatitis leaves a distinct pathological signature on the gland. Let's talk about the pathology.
The hallmark of all forms of chronic pancreatitis is fibrosis. This starts as perilobular fibrosis surrounding individual acini, then progresses to encompass small lobules and eventually coalesces to replace larger areas of acinar tissue.
Scarring takes over.
The pathogenesis involves the activation of quiescent pancreatic stellate cells, or PSCs. These cells, normally containing lipid vacuoles, respond to pancreatic injury by proliferating, losing their lipid vesicles, and transforming into myofibroblasts-like cells.
Right, we mentioned those earlier.
Exactly. These activated PSCs then synthesize and secrete large amounts of collagen and fibronectin, contributing to the dense scar tissue. Studies indicate that vitamin A metabolites, naturally present in quiescent PSCs, can inhibit this collagen production.
Oh, interesting.
Which offers a fascinating possibility for early intervention to prevent or interrupt the ongoing fibrosis.
So if the initial injury activates these stellate cells, that's what leads to the scarring.
Exactly. The sentinel acute pancreatitis event hypothesis posits that an initial acute episode or repeated injury activates PSCs. While they might revert to a quiescent state if there's no further injury, ongoing insults promote persistent activation, driving the progressive fibrosis.
And stone formation. We often hear about calcific pancreatitis.
Pancreatic stones are primarily composed of calcium carbonate crystals embedded within a protein matrix. The crucial protein involved here is called pancreatic stone protein, or PSP, which has also been known as lithostathine. Lithostathine. This protein normally acts as a potent inhibitor of calcium carbonate crystal growth, preventing stone formation.
What's the alcohol connection with these stones?
In alcoholics and patients with alcoholic chronic pancreatitis, the expression and secretion of lithostathine are dramatically inhibited.
Less inhibitor.
Furthermore, increased levels of protease in the duct fluid of alcoholic patients can degrade existing lithostathine, further reducing its availability. This lack of functional lithostathine allows calcium carbonate crystals to grow unchecked, leading to stone formation.
Right.
What's interesting is that increased pancreatic juice protein levels in alcoholic men can be reversed by abstinence from alcohol, suggesting that in early-stage disease, the availability and effectiveness of lithostathine might be restored with timely intervention. However, calcific stone formation represents an advanced stage of disease, which can further promote injury and symptoms due to mechanical damage to the duct epithelium or obstruction of the ductular network.
And the stones can lead to duct distortion.
Yes. While calcific stone disease indicates advanced disease, the presence of parenchymal and ductular calcifications doesn't always directly correlate with symptoms. However, obstructing stones in the main pancreatic duct are commonly observed and often cause pain due to a ball valve effect in the secreting system, leading to episodes of duct obstruction. Ductular hypertension has been documented with proximal main pancreatic duct stenosis. There's still some debate about whether calculus disease and duct enlargement are causally related, independent events, or simply appear together in late stages.
Given these profound changes, how do we confirm chronic pancreatitis and assess its impact on a patient's life? Let's discuss diagnosis.
The diagnosis of chronic pancreatitis typically involves a multifaceted approach, combining clinical presentation, indirect measurements of pancreatic function, and, most importantly, various imaging studies.
What are the gold standards and newer tools in imaging?
For imaging, plain film radiography can sometimes show calcifications. Transabdominal ultrasonography, US, is a common screening tool, though its sensitivity is operator-dependent. It can reveal duct dilation, filling defects, cysts, and a heterogeneous texture. However, endoscopic ultrasound, EUS, has heavily impacted evaluation. It provides very high-resolution images, detecting abnormalities as small as 2 to 3 millimeters, and can even disclose indolent or unsuspected cancers, which occur in up to 10% of patients with chronic pancreatitis.
EUS is key.
EUS is key. Crucially, EUS also allows for fine needle aspiration to obtain cytologic and chemical samples. It's comparable to ERCP for advanced changes and more sensitive for mild disease. This allows ERCP to be reserved for therapeutic maneuvers.
And CT scans?
Computed tomography CT scanning has broadly impacted pancreatic disease diagnosis. Modern helical CT provides clear visualization of the pancreas's nature, extent, location, and relationships. It detects duct dilation, calculi, cystic changes, and inflammatory events.
Right.
While its false negative rate for chronic pancreatitis is low, it can miss early or mild changes, and it has lower sensitivity for small neoplasms.
What about MRI and MRCP?
Magnetic resonance imaging, MRI, particularly with MRCP, magnetic resonance cholangiopancreatography, has significantly enhanced imaging options. MRCP, using T2 weighted imaging, effectively visualizes fluid-filled ducts and cystic lesions.
Sees the fluid well.
Sees the fluid very well. Its resolution is approaching that of CT, and its non-invasive nature and lack of ionizing radiation make it the safest method for imaging the ductal system in high-risk patients, especially for detecting ductal abnormalities and confirming the need for interventional procedures.
And ERCP, which you mentioned, is the gold standard.
Yes, endoscopic retrograde cholangiopancreatography, ERCP, remains the gold standard for the diagnosis and staging of chronic pancreatitis. Beyond diagnosis, it's a versatile tool for therapeutic maneuvers, such as obtaining biopsies for cytology, placing stents to relieve obstruction, or draining pseudocysts.
Diagnosis and therapy.
Both. Its findings are highly correlative with the degree or stage of chronic disease, as codified by the Cambridge classification system, which standardizes morphological findings from ERCP, CT, and US for diagnosis and staging.
So imaging seems to be the primary diagnostic method. Are laboratory studies less definitive for chronic pancreatitis?
They are. While direct measurement of enzymes like lipase and amylase in the blood is highly sensitive for acute pancreatitis, it's seldom helpful for diagnosing chronic pancreatitis.
Not helpful for chronic.
Not really. For endocrine function, the pancreatic polypeptide, PP, response to a test meal correlates most strongly with CP severity, with severe cases showing a blunted or absent response. However, a normal PT response doesn't rule out early disease. Direct pancreatic exocrine secretion measurements involving aspiration of pancreatic juice after stimulation are performed in some specialized centers, but they are invasive and not routinely used.
What about indirect tests of exocrine function?
Indirect tests are less invasive. The benturamide test measures urinary PIBA after ingestion. It's sensitive for severe CP, but less so for mild disease and can have false positives. Stool fat quantification, either direct measurement of fecal fat or breath tests, are used but can have high false negative rates.
Measuring fat in the stool.
Right. Simpler, less expensive tests include fecal chymotrypsin and elastase measurements, which correlate well with loss of pancreatic function. Fecal elastase levels above 200 angers are considered normal, while levels below 100 angers indicate pancreatic exocrine insufficiency, though their sensitivity for mild to moderate CP is limited.
Okay.
Ultimately, imaging, especially EUS, has become the preferred method due to its high resolution.
The pain of chronic pancreatitis can be relentless, but it's not the only way this disease impacts a patient's life. It can also profoundly affect digestion and even lead to a unique form of diabetes. Let's talk about the presentation, natural history, and complications.
Pain is indeed the dominant symptom in chronic pancreatitis. Patients typically describe a severe, constant epigastric pain, which often radiates through to the mid-back. They often try to alleviate it by flexing their abdomen or sitting or lying in a fetal position, remaining still.
Just trying to find relief.
Exactly. Nausea, vomiting, and anorexia are also common accompanying symptoms. This chronic debilitating pain is one of the most unforgiving aspects of the disease.
What causes this relentless pain?
Pain in chronic pancreatitis has multiple etiologies. One major cause is ductal hypertension from strictures or stones, where the buildup of pressure in the pancreatic ducts is often exacerbated by eating.
Pressure buildup.
Right. There can also be persistent pain related to parenchymal disease or retroperitoneal inflammation, which involves ongoing neural irritation. Acute exacerbations of pain on top of chronic pain might be due to sudden increases in duct pressure or recurrent acute inflammatory episodes superimposed on chronic disease.
What's fascinating here is the phenomenon of burned-out pancreatitis. Can you explain that?
This is a remarkable and often tragic aspect of the natural history. In some patients, the pain of chronic pancreatitis may decrease or even disappear completely over years.
The pain goes away.
It can. This phenomenon, known as burned-out pancreatitis, correlates with the progression of the disease to severe destruction of the pancreas, at which point symptoms of exocrine and endocrine deficiency become far more apparent.
So the pain stops because the organ is destroyed.
Essentially. While some might interpret this as a reason to avoid intervention in painful chronic pancreatitis, it's a dangerous simplification. Non-interventional approaches are often inevitably accompanied by the development of narcotic addiction, inability to work, and the severe sequelae of chronic illness. It's a cruel paradox, where the pain subsides only because the organ is so ravaged.
So the pain isn't just about ductal pressure. There's a neural component too.
Absolutely. While increased ductal pressure certainly contributes, chronic inflammation itself and the actual development of nerve damage within the diseased gland play a significant role.
Nerve damage.
Yes. Chronic inflammation leads to an infiltration of tissue by macrophages, which secrete prostaglandins and other pain-inducing agents that cause chronic stimulation of afferent neural fibers. Furthermore, inflammatory damage to the perineurial layers surrounding the unmyelinated pancreatic nerves and a focal infiltration of inflammatory cells around these nerves strongly suggests that the neural fibers themselves are a direct target of the inflammatory response in the pancreas. This structural damage to nerves makes the pain particularly intractable.
That sounds incredibly complex. How are these pain syndromes treated?
The complexity of pain in chronic pancreatitis has led to a distinction between visceral pain, caused by inflammation directly in and around the pancreas, and central sensitization of pain.
Central sensitization.
Yeah, the latter is a syndrome of increased pain perception and sensitivity caused by the prolonged presence of pain, essentially a rewiring of the nervous system. Newer drugs like pregabalin and tramadol specifically target this central sensitization. Strategies to relieve pain are therefore based on three main approaches. First, reducing pancreatic secretion and/or decompressing the secretory compartment. Second, resecting the focus of chronic inflammatory change. And third, interrupting the transmission of afferent neural impulses through neural ablative procedures like celiac plexus blocks.
Beyond pain, how does chronic pancreatitis affect digestion?
A major consequence is malabsorption and subsequent weight loss. Diarrhea and steatorrhea, which is excess fat in the stool, typically develop when the pancreatic exocrine capacity falls below a critical threshold, specifically less than 10% of normal.
Below 10% function.
Right. Patients often describe their stool as bulky, foul-smelling, loose, pale in color, and floating on the toilet water, often with a greasy or oily appearance, an oil slick.
The classic steatorrhea description.
Exactly. Despite sometimes having a good appetite, patients frequently experience significant weight loss, either due to the malabsorption itself or diminished food intake because of abdominal pain.
But what about diabetes? This is a unique form, right?
Yes, this is pancreatogenic diabetes, or type 3C diabetes, T3CDM. While islets, the endocrine tissue, are preferentially conserved early on in chronic pancreatitis, their progressive destruction eventually leads to endocrine insufficiency.
Okay.
Frank diabetes is seen in about 20% of chronic pancreatitis patients initially, but impaired glucose metabolism can be detected in up to 70%. In alcoholic chronic pancreatitis, a high percentage can develop overt diabetes within 25 years of onset, with many requiring insulin.
This raises an important question. Why is this form of diabetes particularly difficult to manage, often called brittle diabetes?
It's brittle because its pathophysiology is distinct from both type 1 autoimmune and type 2 obesity-related diabetes. In T3CDM, the loss of functioning pancreatic tissue, whether from disease or surgical removal, results in a global deficiency of all three glucoregulatory islet cell hormones: insulin, glucagon, and pancreatic polypeptide.
All three are deficient.
All three. This creates a paradoxical situation. There's both an enhanced peripheral sensitivity to insulin and a decreased hepatic sensitivity to insulin.
Wow, that's tough.
It is. As a result, insulin therapy is exceptionally challenging. Patients can be hyperglycemic due to insufficient insulin and unsuppressed hepatic glucose production, or dangerously hypoglycemic if insulin replacement is barely excessive, because they lack pancreatic glucagon to counteract the low blood sugar and often experience hypoglycemia unawareness.
It's very hard to balance.
Very hard. This makes it truly unforgiving to manage. While ketoacidosis and diabetic nephropathy are less common, retinopathy and neuropathy occur at similar frequencies to type 1 and 2 diabetes. This T3CDM is common after pancreatic resection and is also seen in cystic fibrosis, pancreatic cancer, and severe hemochromatosis.
Okay.
Notably, PP deficiency correlates with CP severity, and PP administration can improve hepatic insulin sensitivity and reduce insulin requirements, making TP analogs a promising area of research.
Beyond pain and diabetes, what other complications can arise?
Chronic pancreatitis can lead to a host of local and systemic complications. Local complications include the development of pseudocysts, as well as duodenal or gastric obstruction from inflammatory masses. Splenic vein thrombosis can occur, leading to left-sided portal hypertension and gastric varices with a risk of bleeding. Cause bile duct stenosis or portal vein compression. Duct strictures and stones lead to ductal hypertension and dilation, and pancreatic duct leaks with ascites or fistulas can also occur. The most concerning long-term complication is the progressive, cumulative increased risk of pancreatic carcinoma.
This is profound insight. You mentioned pancreatic carcinoma risk. How significant is this, and what does it mean for patients?
The risk is substantial, and this is a truly unforgiving aspect of chronic pancreatitis. Patients with chronic pancreatitis have a progressively and cumulatively increased risk of developing pancreatic carcinoma throughout their lives, at least tenfold greater than for age-matched controls.
10 times higher.
At least. Even more striking, if chronic pancreatitis is accompanied by diabetes, the risk of carcinoma is increased 12 to 33-fold compared to healthy individuals.
33-fold, wow.
It's a huge increase. In patients with advanced chronic pancreatitis, undiagnosed carcinoma can be present in as many as 10% of cases. The development of cancer in this setting is often cryptic and difficult to diagnose early due to the underlying inflammation masking symptoms.
Right, hidden by the inflammation.
Exactly. This heightened risk absolutely justifies close surveillance for cancer in patients with chronic pancreatitis, typically involving periodic measurements of tumor markers like CA19-9 and imaging with CT scans in the U.S. Furthermore, surgical procedures for presumed chronic pancreatitis should always include a biopsy of the tissue to definitively exclude malignancy. Very crucial. This isn't just a statistic. It means that for these patients, every follow-up appointment carries a unique weight, blurring the lines between managing a chronic condition and constantly screening for a deadly hidden enemy. It's a profound shift in how both patients and doctors must approach this disease.
With such a complex and debilitating condition, treatment is multi-pronged, ranging from medication to highly specialized surgery. Let's explore the treatment approaches for chronic pancreatitis.
Medical therapy for chronic pancreatitis often begins with enzyme therapy. Pancreatic enzyme administration is crucial for reversing the effects of pancreatic exocrine insufficiency, which prevents secondary complications like metabolic bone disease that arise from inadequate absorption of fat-soluble vitamins.
Right, replacing the enzymes.
Exactly. Enzyme replacement may also help reduce or alleviate pain.
Is there a specific type of enzyme preparation that's better for pain?
It depends on the goal. Conventional non-enteric-coated enzyme preparations, although partially degraded by gastric acid, are thought to provide pain relief by downregulating CCK released in the proximal gut, which theoretically reduces pressure within an obstructed pancreatic duct.
Okay, the non-coated ones for pain, maybe.
Maybe. Enteric-coated preparations, while protected from acid, offer little to no pain relief. So for pain relief, a trial of non-enteric-coated enzyme supplements combined with an acid-suppressive medication is often recommended. If pain relief isn't achieved, further investigation of the ductal system by ERCP is warranted.
Okay.
Antisecretory therapy, using somatostatin analogs like octreotide, can also inhibit pancreatic exocrine secretion and CCK release, which might help reduce pain.
Endoscopic management seems to have an expanded role now.
It truly has. Over the past 20 years, endoscopic techniques for treating pancreatic duct obstruction, stone disease, pseudocysts, duct leaks, and even for diagnosing and managing associated pancreatic tumors have greatly expanded.
Doing more with a scope?
A lot more. Techniques include sphincterotomy for both biliary and pancreatic ducts, stricture dilation and stenting, extracorporeal shockwave lithotripsy to break up pancreatic duct stones, and stone extraction.
Lithotripsy for pancreas stones.
Yes, breaking them up with sound waves. For patients with pancreas divisum, endoscopic stenting through the lesser papilla can offer temporary pain relief and help predict who might benefit from more permanent surgical or endoscopic interventions. Pancreatic duct stenting also facilitates the resolution of duct leaks.
Now, let's talk about surgical therapy. Traditionally, it was considered a last resort. Has that view changed?
Yes, the traditional view was that surgery should only be considered after medical therapy for symptoms had failed. However, in 1993, a landmark study showed that surgical duct decompression could actually delay or prevent the progression of chronic obstructive pancreatitis.
Surgery could be preventative?
In a way, yes. This study demonstrated a proactive role for surgery in the earlier management of the disease, moving it beyond just a salvage procedure.
What are the challenges and considerations for surgery?
Despite these advances, challenges remain. For instance, in cases of small duct disease or minimal change chronic pancreatitis, the choice of operation can be uncertain. Major resections carry a high early and late complication rate, especially in alcoholic chronic pancreatitis, while lesser procedures often result in symptom recurrence.
Right.
Therefore, the choice and timing of surgery are highly individualized based on the patient's specific pancreatic anatomy, the likelihood of success with medical or endoscopic therapy, and the balance of risks versus benefits. Preoperative preparation is also vital, focusing on restoring protein-caloric homeostasis and, crucially, complete abstinence from alcohol and tobacco.
So surgeons developed hybrid procedures combining resection and drainage to try and get the best of both worlds.
Precisely. These hybrid procedures aim to address the inflammatory nidus in the pancreatic head while also providing effective drainage. One notable example is a duodenum-preserving pancreatic head resection, DPPHR, also known as the Bager procedure.
The Bager procedure.
Right. This involves resecting the pancreatic head while preserving the duodenum and common bile duct. Long-term follow-up showed high rates of pain relief with very low mortality and a surprisingly low rate of new-onset diabetes.
Better outcomes.
Seems so. Randomized trials have shown that DPPHR is associated with shorter hospital stays, greater weight gain, and less postoperative diabetes and exocrine dysfunction compared to the Whipple procedure with similar pain control.
And the Frey procedure.
The local resection of pancreatic head with longitudinal pancreaticoduodenectomy, LRLPJ, or Frey procedure, involves excavating the pancreatic head, including its ductal structures, in continuity with a long incision of the dorsal duct, then connecting it to a side-to-side root-en-Y pancreaticoduodenectomy.
Currying out the head and connecting it.
Essentially. This provides thorough decompression of the entire ductal system from head to tail. It boasts high rates of pain relief, no operative mortality in reported series, and a relatively low complication rate.
So when we compare these three main operative procedures, the Whipple, DPPHR, and Frey, what does the evidence-based data tell us?
The comparison of these procedures has been a major focus of surgical research. While the Whipple procedure, or pancreaticoduodenectomy, has a place, particularly when malignancy is a concern, studies comparing it to the duodenum-preserving options, DPPHR and LRL-LTJ, show that DPPHR patients often have a shorter hospital stay, greater weight gain, and less immediate postoperative diabetes and exocrine dysfunction,
Right.
with similar long-term pain control. Long-term studies, including randomized trials, have shown no significant differences between DPPHR and LR-LPJ in terms of global quality of life, pain scores, or late mortality.
So DPPHR and Frey are pretty similar long-term.
Pretty similar. While DPPHR and LR-LPJ may have lower initial rates of endocrine dysfunction compared to pancreaticoduodenectomy, the long-term risk of developing diabetes appears similar across all groups, suggesting it's more related to the progression of the underlying disease than the specific operation.
Ah, the disease itself progresses.
Exactly. Both DPPHR and LR-LPJ have also shown efficacy in patients with both dilated and non-dilated pancreatic ducts. Essentially, for chronic pancreatitis without strong suspicion of malignancy, the organ-preserving approaches are generally favored due to their lower immediate morbidity and better preservation of function.
Now, let's address the surgical complications that can arise from these complex procedures and how they're managed. This is where the unforgiving nature of the pancreas truly shows itself.
Postoperative complications are unfortunately still very common, even in specialized centers. One major concern is anastomotic techniques, how the remaining pancreatic tissue is reconnected to the intestine. Whether a pancreaticoduodenectomy, connecting to the jejunum, or a pancreaticogastrostomy, connecting to the stomach, is used, there's no clear objective superiority in terms of reducing the pancreatic fistula rate, which hovers around 10% in most series.
Still about a 10% leak rate.
Roughly. Surgeon preference, often based on experience, plays a significant role.
Drains are often placed, but is that always beneficial?
Traditionally, drains are routinely placed around pancreatic and biliary anastomoses because a disruption of the pancreaticoduodenostomy can occur in about 10% of patients. This can lead to an abdominal abscess or an external pancreatic fistula.
Right.
Pure pancreatic leaks often seal spontaneously with drainage. However, combined pancreatic and biliary leaks are far more dangerous because bile activates pancreatic enzymes, leading to necrotizing retroperitoneal infection that can erode major arteries and veins, sometimes heralded by a small sentinel bleed from the drain site.
A herald bleed, okay.
A warning sign. Such events require immediate attention, often angiography or reoperation. The practice of routine drain placement is actually debated, as some studies suggest it might increase mortality if a leak does occur post-pancreaticoduodenectomy. If no fistula develops, drains should be removed early, ideally by post-operative day 5.
What about feeding tubes?
Routine placement of feeding jejunostomy or gastrostomy tubes has become less common. They are now used selectively for malnourished patients or those who have received neoadjuvant chemotherapy and are predicted to have severe gastroparesis.
Selective use now.
Yes. While feeding tubes carry their own risks, like leaks or intestinal obstruction, parenteral nutrition also has serious complications.
The risk of cancer looms large in chronic pancreatitis. But the pancreas can also develop other forms of cancer, each with its own unique characteristics and challenges. Let's move to the threat of tumors, pancreatic neoplasms.
We'll start with neoplasms of the endocrine pancreas, often called pancreatic neuroendocrine tumors or pancreatitis. These are relatively uncommon, but they are important. The islet cells from which these tumors arise originate from specialized cells with neuroendocrine properties.
Neuroendocrine tumors, pancreatitis.
Right. These tumors are notable because they can be part of multiple endocrine neoplasia, MEN1 syndrome, which involves tumors in the pituitary gland, parathyroid hyperplasia, and pancreatic neoplasms.
Are these tumors always functional, meaning they secrete hormones?
No. They are classified as either functional or non-functional. Functional tumors secrete excess hormones, leading to recognizable clinical syndromes, which we'll discuss. However, the majority are non-functional, meaning they don't produce symptoms from hormone excess.
Okay.
Crucially, the malignancy of these tumors is determined by the presence of local invasion or lymph node and hepatic metastases, not solely by their histological appearance.
Behavior determines malignancy, not just looks.
Exactly.
How are they typically imaged and diagnosed?
The initial diagnostic imaging of choice for pancreatic endocrine tumors is a multi-detector CT scan with 4 phases of contrast and fine cuts through the pancreas and liver, as these tumors often enhance brightly with contrast.
Bright on CT.
Often. Endoscopic ultrasound, EUS, can be superior to CT for localizing these tumors, especially because they can be quite small, often less than 1 centimeter, yet still produce dramatic symptoms.
EUS for small ones.
Yes. Unlike exocrine tumors, many endocrine tumors possess somatostatin receptors, making them detectable by a radio-labeled octreotide scan,
Octreotide scan.
where a radioactive somatostatin analog is injected intravenously, followed by whole-body radionuclide scanning.
Let's talk about specific functional tumors, starting with insulinoma.
Insulinomas are the most common functional pancreatic endocrine neoplasms. They classically present with Whipple's triad, which consists of symptomatic fasting hypoglycemia, a documented serum glucose level below 50 milli-GDL, and relief of symptoms upon glucose administration.
Whipple's triad for insulinoma.
Right. Patients can experience a range of symptoms from profound syncopal episodes to palpitations, trembling, diaphoresis, confusion, seizures, and even personality changes. Diagnosis involves confirming low blood sugar, elevated serum insulin levels, and importantly, elevated C-peptide levels.
Checking the C-peptide.
Crucial. A monitored fast where blood is sampled every few hours until symptoms appear can confirm the diagnosis, but it must be performed under strict supervision due to the danger of severe hypoglycemia.
And there's a specific syndrome of hypoglycemia that's not an insulinoma.
Yes. The non-insulinoma hyperinsulinemia hypoglycemia syndrome was described in 1999. It's associated with beta cell hypertrophy, islet hyperplasia, and increased beta cell mass.
Not a tumor, but too many beta cells.
Kinda, yes. While historically considered a disease of neonates, dozens of cases have now been reported in adults, typically after Roux-en-Y gastric bypass surgery for obesity.
And after gastric bypass.
Yeah. This condition in post-bariatric surgery patients appears to stem from a prolonged idiosyncratic hypersecretion of incretin hormones. The appropriate treatment for this is not pancreatic resection alone, as this often leads to recurrence. Instead, it involves converting the gastric bypass to a bariatric procedure that restores normal intestinal nutrient flow, or adding a restrictive element.
What about gastrinoma, which causes Zollinger-Ellison syndrome?
Gastrinomas secrete gastrin, leading to a condition called Zollinger-Ellison syndrome, ZES, characterized by profound acid hypersecretion and severe peptic ulceration.
Too much acid.
Way too much acid. Patients typically present with abdominal pain, recurrent or atypical peptic ulcers that don't respond to standard antacid therapy, severe esophagitis, and about 21% experience diarrhea. Diagnosis involves measuring serum gastrin levels. Gastrinomas are typically found within a region known as Pissarro's triangle,
Pissarro's triangle.
which includes the head of the pancreas, the duodenum, and the lymphatic bed posterior and superior to the duodenum. Surgical resection is the treatment for localized disease.
And the other rare ones.
VBOMAs, or vasoactive intestinal peptide-secreting tumors, cause the classic WDHA syndrome. Watery diarrhea, hypokalemia, and achlorhydria. Most are large, located in the tail of the pancreas, and often metastasize.
WDHA syndrome.
Right. Glucagenomas are particularly fascinating. They present with a classic triad: diabetes, necrolytic migratory erythema, a cyclical rash on the lower abdomen, perineum, perioral area, and feet, and an enlarged sensitive tongue.
That distinctive rash.
Very distinctive. Malnutrition is common. Diagnosis is by elevated serum glucagon levels. Like VBIPOMAs, they're often large in the body or tail and frequently metastatic. Somatostatinomas inhibit both pancreatic and biliary secretions. Patients present with gallstones due to bile stasis, diabetes from inhibited insulin secretion, and stearia due to inhibited exocrine and bile secretion. Most are found in the proximal pancreas or pancreatoduodenal groove. Diagnosis is by elevated serum somatostatin. Complete excision is warranted in fit patients if possible.
So those are the functional tumors. What about non-functioning pancreatic endocrine tumors, PNTs?
Non-functional PNETs are not associated with elevated hormone levels causing symptoms. The majority of these are malignant, meaning they have the potential for uncontrolled growth and metastasis.
Malignant potential, even if non-functional.
Yes. For small, non-functional PNETs, particularly in N1 patients, observation is sometimes considered due to the significant morbidity and mortality of pancreatic resection. However, for sporadic cases, radical surgery with curative intent is the standard of care. Cytoreductive surgery for metastatic PNETs is controversial, while consensus guidelines suggest aggressive resection if over 90% of the tumor burden can be removed. This is only feasible in about 10% of metastatic cases.
While neuroendocrine tumors are rare, the most aggressive and common pancreatic cancer is a different beast entirely, and its prognosis is grim. Let's delve into neoplasms of the exocrine pancreas, specifically pancreatic ductal adenocarcinoma, or PDAC.
The statistics for PDAC are indeed grim. It carries the worst prognosis of all major malignancies with a very low 5-year survival rate. Its incidence is rising, and is projected to become the leading cause of cancer deaths in the U.S. by 2050.
Leading cause soon. That's sobering.
Very sobering. The exact cause is unknown, but it involves a complex interplay of genetic and environmental factors.
What are the key risk factors for PDAC?
PDA is more common in older adults, and is slightly more common in African Americans and men. A family history of pancreatic cancer in a first-degree relative roughly doubles the risk. Up to 10% of cases are linked to inherited genetic predispositions, including mutations in BRCA2 and hereditary pancreatitis, among others.
Okay.
Cigarette smoking is a consistently linked and significant risk factor, increasing the risk at least twofold due to carcinogens.
Smoking's a big one.
A very big one. Diets high in fat and low in fiber, fruits, and vegetables are also thought to be associated.
Diabetes is also strongly linked, isn't it?
Yes. Glucose intolerance is present in a high percentage of PDA patients. Pre-existing type 2 diabetes increases the risk. Crucially, the new onset of diabetes in an older adult or a sudden unexplained increase in insulin requirements in a patient with pre-existing diabetes should prompt a rigorous search for pancreatic cancer.
A red flag.
A major red flag, as it can be an early manifestation of an otherwise occult tumor.
And chronic pancreatitis itself is a risk factor for cancer.
Absolutely. Patients with chronic pancreatitis have a significantly increased risk of developing pancreatic cancer, up to a 20-fold increase. This risk seems independent of the type of pancreatitis, and smoking further accelerates cancer development in chronic pancreatitis patients.
Right.
Molecularly, the disease is understood as a progression through precursor lesions called pancreatic intraepithelial neoplasia, or PENNEN. These are microscopic changes that can precede invasive cancer.
Where are these tumors typically found, and how does that affect prognosis?
About 2/3 of pancreatic adenocarcinomas arise within the head or unspacitate process of the pancreas. About 15% are in the body and 10% in the tail.
Mostly in the head.
Mostly in the head. Tumors in the body and tail tend to be larger at diagnosis and are therefore less commonly resectable. Head tumors, however, are often diagnosed earlier because their location can cause obstructive jaundice, which brings patients to medical attention.
Jaundice is an early sign for head tumors.
Often, yes. Ampullary carcinomas, distal bile duct carcinomas, and periampullary duodenal adenocarcinomas, while similar in presentation, generally have a slightly better prognosis because the early onset of jaundice often leads to earlier diagnosis and intervention.
So early diagnosis is a major challenge for pancreatic cancer. How is it diagnosed and staged?
Early diagnosis is the most critical deficit in treating pancreatic cancer effectively. The pancreas is deep and early symptoms are often vague. Most patients present with pain, jaundice, and weight loss, which are unfortunately signs of advanced disease.
Late symptoms.
Often late. While it's often taught that pancreatic cancer presents with painless jaundice, this isn't accurate. Most patients experience pain, often vague and perceived in the epigastrium but radiating to the back, for months before diagnosis.
So pain is common.
Very common. This is why clinicians should maintain a low threshold for ordering a multi-detector CT scan with a pancreatic protocol for older adult patients with unexplained, persistent, even vague abdominal pain. As mentioned, new onset diabetes in older adults is also a significant red flag.
What's the best imaging for diagnosis and staging?
The current diagnostic and staging test of choice is a multi-detector dynamic contrast-enhanced CT scan. It's highly accurate, about 90–95%, for predicting unresectable disease.
Good at ruling out surgery.
Yes. However, it's less accurate for predicting resectable disease, sometimes missing small liver metastases or arterial involvement. CT findings indicating unresectability include extensive involvement of major vessels like the celiac axis, hepatic artery, or superior mesenteric artery, enlarged lymph nodes outside resection boundaries, sites, or distant metastases.
Okay.
Involvement of the portal vein or superior mesenteric vein is not an absolute contraindication if the veins remain patent. Tumors are considered borderline resectable if there's limited major artery involvement or short segment vein occlusion or suspicious but uncharacterized small liver lesions.
Borderline resectable.
Right. There's a growing consensus that neoadjuvant treatment should be considered for all borderline resectable cases. Other modalities like MRI offer similar information, and PE scans can rule out distant metastases. EUS is valuable for detecting small masses missed by CT and provides the opportunity for transluminal biopsy.
For unresectable cases, what's the management beyond surgery?
For unresectable disease, managing symptoms is key. Biliary obstruction is typically palliated by endoscopic biliary stents. Duodenal obstruction is usually a late event. Options include endoscopic metallic duodenal stents or surgical bypass via gastrogynostomy.
Stents or bypass?
Right. While endoscopic stents have less initial morbidity, surgical bypass is generally more durable.
What about chemotherapy and radiation for locally advanced or metastatic disease?
The role of radiation therapy for unresectable, locally advanced pancreatic cancer is controversial. While it may slow local progression and alleviate symptoms like pain or obstruction, it's not curative due to the high likelihood of micrometastatic disease. Stereotactic body radiotherapy, SBRT, a high-dose, short-course approach, can enhance local response.
SBRT.
SBRT. Chemotherapy regimens, while not achieving long-term cures for most, do offer symptomatic improvement. Gemcitabine was the standard for unresectable disease, improving symptoms and quality of life. More recently, multi-drug regimens like
Fulfirinox, yeah.
have shown improved overall survival for metastatic disease, though with higher toxicity. Other regimens like albumin-bound paclitaxel plus gemcitabine have also improved survival.
Let's circle back to surgical resection, specifically the Whipple procedure.
The Whipple procedure, or pancreaticoduodenectomy, involves removing the pancreatic head, duodenum, gallbladder, and part of the bile duct, followed by complex reconstruction. A thorough assessment for resectability is paramount, examining the liver, peritoneum, and major vessels for tumor spread.
Major surgery.
Very major. The relationship of the tumor to the mesenteric vessels is crucial, determined by a high-quality preoperative CT scan. An important anatomical variation to watch for is the replaced right hepatic artery, which travels behind the pancreas and must be identified to avoid liver damage.
Did I find that artery?
Absolutely. The pancreatic neck is then carefully divided, and the pancreatic head is dissected off the major veins.
After the resection, how is the digestive tract reconstructed?
The reconstruction involves creating multiple connections. The pancreas first, then the bile duct, and finally the duodenum or stomach. For the pancreaticoduodenectomy, various techniques exist. Despite variations, the clinically significant pancreatic leak rate remains a challenge.
Still around 10%.
Yeah. The choledochoduodenectomy connects the bile duct, and finally, the duodenoduodenectomy or gastrojejunostomy connects the remaining digestive tract.
What if the tumor involves major blood vessels?
Involvement of the superior mesenteric artery, celiac axis, or hepatic artery typically indicates a locally advanced tumor, which is usually unresectable. However, involvement of the portal vein or superior mesenteric vein does not necessarily preclude resection if the veins remain patent.
Vein involvement isn't always a deal breaker.
Not always. Reconstruction can often be achieved by rejoining the vein ends or using a vein graft. While these extended resections carry increased morbidity and mortality in general settings, outcomes are acceptable in very high-volume centers, especially with neoadjuvant therapy.
Are there minimally invasive options for pancreatectomy?
Yes, laparoscopic distal pancreatectomy has become a safe and appropriate approach for removing the body and tail of the pancreas, offering benefits like decreased blood loss and quicker recovery.
Lap distal is well established.
Pretty much. Laparoscopic pancreaticoduodenectomy, or laparoscopic Whipple, is also gaining interest. While feasible and shown comparable outcomes to open procedures in expert hands, it requires considerable expertise.
Lap Whipple is harder, much harder. Let's summarize the common complications of pancreaticoduodenectomy.
Despite remarkable improvements, complications are common. Mortality has decreased to less than 5% in high-volume centers. The most frequent complications include delayed gastric emptying, pancreatic fistula, and hemorrhage.
Fistula is a big one.
A very big one. A pancreatic fistula, a leak from the pancreatic connection, can lead to an abscess or an external fistula. Pure pancreatic leaks often seal spontaneously, but combined biliary pancreatic leaks are dangerous because bile activates pancreatic enzymes, potentially causing erosion of major vessels and life-threatening hemorrhage. The routine placement of drains is still debated. If no fistula develops, drains should be removed early.
What about the overall outcome and value of pancreaticoduodenectomy for cancer?
While few patients with pancreatic cancer are cured indefinitely by pancreaticoduodenectomy, it remains the only chance for cure. Studies have shown a striking underuse of pancreatectomy in the U.S.
Underused.
Strikingly underused. with a significant percentage of early-stage patients not undergoing surgery, often due to age, ethnicity, socioeconomic factors, or being treated at low-volume centers. Patients not offered surgery had worse survival, suggesting overall survival for PDAIR would significantly increase if more eligible patients were identified and operated on at high-volume centers.
What's the role of adjuvant and neoadjuvant therapy?
Traditionally, adjuvant therapy given after surgery was based on specific chemotherapy drugs. However, encouraging results with newer regimens are driving trials for their use in the adjuvant setting. In the U.S., adjuvant chemotherapy, sometimes combined with chemoradiation, is typical practice for patients with acceptable functional status after surgery.
Okay, adjuvant after surgery.
Right. Neoadjuvant treatment given before surgery offers several potential advantages. It avoids treatment delays from postoperative complications, can decrease tumor burden, and kill microscopic spread before surgery.
Treat first, then operate.
Yes. It also helps identify patients with occult metastatic disease, allowing them to avoid unnecessary surgery. It doesn't increase perioperative morbidity or mortality, and may even decrease fistula rates. Neoadjuvant therapy is associated with lower lymph node positivity and improved survival in responders, making it an acceptable alternative to surgery-first approaches.
Finally, what about periampullary adenomas? Are they always cancerous?
Periampullary adenomas are benign tumors arising at the ampulla. However, it's difficult to distinguish them from cancer by biopsy, with high false negative rates.
Biopsy isn't reliable.
Not always. Small adenomas with no evidence of invasion can be locally excised, either endoscopically or surgically. However, if a preoperative biopsy confirms cancer, or if a local excision reveals invasive cancer on final pathology, then a pancreaticoduodenectomy is required.
Beyond solid tumors, the pancreas can also develop a bewildering array of cystic lesions, each with its own potential for malignancy and unique management strategy. Let's decode these fluid-filled lesions. This is another area where early, precise identification is key.
Pancreatic cystic neoplasms, or fluid-containing lesions, are increasingly identified incidentally with the rising use of CT and MRI, found in about 9% of people over 80 years old.
Found more often now.
Much more often. While symptomatic cysts are typically resected, asymptomatic cysts pose a significant management dilemma. The overall risk of an incidental pancreatic cyst being malignant is very low, yet pancreatic surgery carries significant risks.
Right. The surgery is risky.
It is. However, some of these neoplasms can slowly transform into invasive adenocarcinoma, representing a crucial opportunity for surgical cure before malignant transformation. The surgeon's challenge is to identify the small minority of cysts that pose a significant risk, balancing the benefits of resection against the risks of surgery.
Tricky balance.
Very tricky. This is a classic example of the unforgiving nature. A benign-appearing lesion could become a deadly threat, but intervening too aggressively has its own costs.
What's the most common cystic lesion, and how is it different from a true neoplasm?
The most common cystic lesion of the pancreas is the pseudocyst. Unlike neoplasms, pseudocysts are non-neoplastic, meaning they don't have an epithelial lining. They are a complication of pancreatitis or pancreatic duct injury, and their fluid typically contains a high amylase content.
High amylase means pseudocyst likely.
Often. The danger lies in mistaking a true cystic neoplasm for a pseudocyst and incorrectly draining it into the GI tract rather than resecting it. For this reason, a biopsy of the pseudocyst wall is often a required step in their management to rule out a true neoplasm.
How do serous cystadenomas fit in?
Serous cystadenomas are typically found in older women and are almost always benign. They have a characteristic spongy appearance made up of multiple small cysts, referred to as microcystic.
Microcystic, okay.
The fluid within is thin and serous, contains no mucin, and has a low CEA level. Imaging often reveals a central scar with calcification. Resection is indicated for symptomatic patients. For asymptomatic cases, conservative management with surveillance is often adopted, confirmed by EUSFNA showing non-viscous fluid with low CEA and amylase.
And what about mucinous cystic neoplasms? Are they always benign?
Mucinous cystadenoma and cystadenocarcinoma, MCNs, represent a spectrum of disease, ranging from benign with malignant potential to highly aggressive carcinoma. Their heterogeneity makes biopsy unreliable for excluding malignancy.
Biopsy isn't enough for MCNs.
Often not. MCNs are commonly seen in perimenopausal women, with about 2/3 located in the body or tail of the pancreas. On imaging, they have thick walls and, crucially, do not communicate with the main pancreatic duct.
No duct communication.
Right. They are lined by tall columnar epithelium that fills the cyst with viscous mucin. A key pathological feature is a highly cellular ovarian stroma in the submucosal layer. Elevated fluid CEA levels suggest a mucinous lesion and potentially malignant transformation.
How are MCNs managed?
Resection is the treatment of choice for most mucin-producing cystic tumors because malignancy cannot be definitively ruled out without complete removal and extensive pathological sampling.
You could take them out.
Pretty much. Current thinking is that all MCNs, if left untreated, will eventually evolve into cancer. Distal pancreatectomy is the most common procedure, and the spleen may be spared for smaller lesions. It's critical to remove the tumor intact to avoid rupture. If completely resected without atypia or dysplasia, patients are typically cured.
The last major type are intraductal papillary mucinous neoplasms, or IPMNs. What distinguishes these?
Intraductal papillary mucus neoplasms, IPMNs, typically arise within the pancreatic ducts, usually in the head of the pancreas. They form papillary projections into the duct and produce mucin, causing intraluminal cystic dilation of the pancreatic ducts.
Growing inside the duct.
Inside the duct. On imaging, you'll see diffuse dilation of the pancreatic duct, and the surrounding pancreatic parenchyma might be atrophic. Crucially, they lack the classic features of chronic pancreatitis, like calcification or a beaded duct. A virtually diagnostic sign on ERCP is mucin extruding from the ampulla of Vater, often described as a fisheye lesion.
Fisheye lesion, wow.
Yeah. IPMNs affect men and women equally, usually in older adulthood, presenting with pain or recurrent pancreatitis due to mucin obstruction.
Are there different types of IPMNs, and how does that affect management?
Yes, there are two main types: main duct IPMNs, MD IPMNs, and side branch IPMNs, BD IPMNs. MD IPMNs are considered a strong indication for surgical resection due to their higher malignant potential.
Main duct needs resection.
Generally, yes. BD IPMNs, on the other hand, have a lower incidence of malignancy and are often managed with serial imaging surveillance.
Side branch can be watched.
Often, yes, with careful surveillance.
There's a complex algorithm for managing asymptomatic cysts, right? How do clinicians navigate that?
Yes, the approach for incidentally discovered asymptomatic pancreatic cystic neoplasms is guided by high-risk stigmata or worrisome features on imaging. High-risk stigmata, which necessitate surgical resection, include obstructive jaundice in a head of pancreas cyst, an enhancing solid component within the cyst, or a main pancreatic duct of 10 millimeters greater.
Immediate red flag.
Immediate red flags. Worrisome features, which prompt further evaluation, include cysts 3 centimeters or larger, thickened or enhancing cyst walls, a main pancreatic duct between 5 and 9 millimeter, a non-enhancing mural nodule, an abrupt change in the main pancreatic duct caliber with distal pancreatic atrophy, or enlarged lymph nodes.
Okay, those need a closer look.
Exactly. If these worrisome features are present, or if a cyst is greater than 3 centimeters without high-risk stigmata, further evaluation with EUS is recommended. Resection is then indicated if EUS reveals a definite mural nodule, suspicious main duct features, or positive or suspicious cytology. This detailed stratification is essential for balancing the risk of malignancy against the risks of surgery.
And if there are no high-risk stigmata or worrisome features?
For BD IPMNs smaller than 3 centimeters without any worrisome features or high-risk stigmata, surveillance is an option. Guidelines suggest periodic surveillance with imaging, and surgery is only considered if multiple concerning features arise on follow-up imaging. This less aggressive approach acknowledges the low immediate risk for these specific cysts, but also recognizes the potential for change over time.
This has been an incredibly deep dive into an organ that truly challenges us. So what does this all mean?
We've journeyed through the intricate landscapes of the pancreas, from its hidden retroperitoneal anatomy and vital dual functions to the complex dance of acute and chronic diseases and the nuanced world of pancreatic tumors.
Yeah.
You now possess a level of understanding that far surpasses casual knowledge, equipping you with insights into why this organ is so unforgiving and yet so essential for life.
We've covered everything from its precise location and blood supply, including critical anatomical variants like the replaced right hepatic artery to its dual exocrine and endocrine functions, delving into the specific enzymes and hormones it produces. We've dissected the triggers and devastating pathophysiology of acute pancreatitis, including the critical role of premature enzyme activation, and explored how we diagnose and manage this life-threatening condition.
And we've illuminated the slow burn of chronic pancreatitis, its complex genetic predispositions, including the fascinating CLDN2 variant that explains male susceptibility to alcoholic pancreatitis, and its unique impact on digestion and the development of brittle diabetes.
Right.
We've also meticulously detailed the spectrum of pancreatic neoplasms, from rare but complex neuroendocrine tumors to the aggressive pancreatic ductal adenocarcinoma and the bewildering array of cystic lesions, understanding their malignant potential and the intricate algorithms guiding their management.
You now understand why the pancreas is called unforgiving by surgeons, how seemingly vague pain can signal serious pathology, and the incredible challenge of managing its diseases. This knowledge empowers you to understand complex medical scenarios, recognize potential red flags, and simply appreciate the hidden wonders and vulnerabilities of your own biology.
As we conclude this deep dive, consider this. The pancreas, often silent until crisis strokes, reminds us of the profound interconnectedness within our own bodies, where a small, hidden organ can dictate our very ability to digest food and regulate life-sustaining sugar levels.
What other unforgiving or unsung organs might hold similar secrets waiting to be uncovered, and how can a deeper understanding of our own biology empower us in unexpected ways?
We hope you've enjoyed this deep dive into the fascinating world of the pancreas.
Join us next time on The Deep Dive.